Universitas Muhammadiyah Jember berdiri atas kesadaran dan prakarsa para tokoh Muhammadiyah dan warga Muhammadiyah di Jember pada tanggal 5 Jumadil Ula 1401 Hijriah atau bertepatan dengan 11 Maret 1981 Miladiah. Pada 1 September 1981, resmi mendapatkan piagam pendirian perguruan tinggi Muhammadiyah dan disetujui oleh Menteri Pendidikan dan Kebudayaan Republik Indonesia pada 10 Mei 1982. Universitas Muhammadiyah Jember menjadi salah satu perguruan tinggi swasta terbaik di Kabupaten Jember, daerah yang penuh dengan kekayaan alam, industri, budaya dan kearifan lokal yang mendunia. 40 tahun berkontribusi pada negeri, mengemban cita-cita yang tertuang dalam visi, yakni menjadi perguruan tinggi yang unggul dalam iptek, bernafaskan nilai-nilai keislaman dengan misi dan tujuan yang selaras. Dalam pencapaiannya, Universitas Muhammadiyah Jember telah berstandar ISO 21001-2018, pula berhasil meraih akreditasi institusi B sesuai dengan sertifikat akreditasi perguruan tinggi oleh BAN PT pada 10 Mei 2020. Memiliki 9 fakultas dan 28 program studi serta program pasca sarjana yang seluruhnya telah berhasil terakreditasi A dan B.
Di Universitas Muhammadiyah Jember, yang namanya COVID ini memang harus diingat oleh semua pihak, sehingga proses belajar mengajar itu semua dilakukan dengan daring. Kita punya standar khusus yang mana di lembaga kita ini kan ada tim MCCC yang mengurusi tentang COVID-19 ini.
Jadi perlu kami sampaikan bahwasanya MC3 sering kita kenal. Jadi tim ini adalah tim yang dibentuk dalam rangka menyikapi adanya wabah COVID-19 di. Jadi kalau berkaitan dengan proses PBM, kami sudah mengikuti langkah pemerintah sejak dinyatakan bahwa COVID masuk Indonesia itu dengan daring. Tetapi tidak menutup kemungkinan bahwasannya itu karyawan, dosen sebagainya itu masih termasuk pimpinan itu masih secara offline di sini supaya semuanya bisa berjalan. Nah, kita titik tekannya adalah bagaimana yang offline ini tetap merasa aman dan nyaman.
Pendidikan yang fleksibel dapat masuk dalam rongga-rongga permasalahan, mengambil strategi untuk pembaharuan dan pengembangan, namun tidak lepas pada tujuannya. Bersamaan dengan hal tersebut, Universitas Muhammadiyah Jember berhasil menjadi 5 besar universitas di seluruh Indonesia dalam menjalankan program studi yang menerapkan kerjasama Merdeka Belajar Kementerian Pendidikan dan Kebudayaan Republik Indonesia. Dalam ranah penelitian, pengabdian, dan publikasi jurnal ilmiah, Universitas Muhammadiyah Jember terus mengalami peningkatan. 31 jurnal ilmiah ber-ISSN dengan 20 jurnal terakreditasi nasional dan 11 jurnal dalam tahap akreditasi, serta 1 di antaranya telah lolos jurnal internasional. Melebarkan sayapnya, Universitas Muhammadiyah Jember telah bekerja sama dengan institusi dan lembaga dalam negeri dan luar negeri dengan penyelenggaraan bentuk-bentuk kerjasama yang berkaitan dengan catur dharma perguruan tinggi, baik secara inisiasi dan kolaborasi yang bermanfaat bagi mahasiswa, dosen, dan institusi. Dengan banyaknya pencapaian yang telah Universitas Muhammadiyah Jember raih, baik dalam akademik dan non-akademik, pula dalam beramal usaha yang telah berhasil mendapatkan hak ciptanya. Kini Universitas Muhammadiyah Jember semakin yakin untuk merencanakan lebih banyak konsep usaha, baik yang didasari dari penelitian maupun secara mandiri oleh universitas. Unit usaha yang terus dikembangkan yakni SPBU, Unit Armada UM Jember Trans, Layanan Kesehatan Klinik Suherman, Pertokoan dan Koperasi, Taman Kanak-kanak dan PAUD Yasmin, serta produk-produk amal usaha lainnya. Universitas Muhammadiyah Jember menjadi salah satu perguruan tinggi Muhammadiyah yang turut berkontribusi sebagai pendiri UMAM atau Universitas Muhammadiyah Antarbangsa Malaysia. Pula menjadi salah satu yang dipercaya menjalankan amanah untuk mendirikan Rumah Sakit Universitas Muhammadiyah Jember.
Universitas Muhammadiyah Jember ini sebenarnya kan kepanjangan dari pimpinan pusat Muhammadiyah itu. Kita ini diberi amanah sudah agak lama sebenarnya, tapi baru tahun ini akan kita laksanakan, yaitu kita akan mendirikan Rumah Sakit Universitas Muhammadiyah, yang mana ini merupakan cikal bakal atau salah satu syarat kalau nanti kita akan mendirikan Fakultas Kedokteran di Universitas Muhammadiyah Jember. Harapan saya selaku Rektor Universitas Muhammadiyah Jember adalah Universitas Muhammadiyah Jember ini menjadi ya sejenis mercusuar lah untuk Muhammadiyah di Jember, terutama di bidang pendidikan. Di samping punya status yang bagus, juga bermanfaat bagi masyarakat sekitar.
Pendidikan menjadi ujung tombak suatu bangsa, inti dari seluruh elemen kehidupan. Universitas Muhammadiyah Jember siap mengemban amanah untuk agama dan bangsa. We love Kampus Biru.
Iki boleh continue? Heeh.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning, ladies and gentlemen. Welcome to International Scientific Meeting in Nursing 2021. Role of Microbiota and Sustaining TB Services in the Pandemic Era. What can we do as a nurse? My name is Diah Ayu Nur Fadila. It is a wonderful and profuse chance for me to be a master of ceremony in this event on Wednesday, July 28 to 29, 2021. In this beautiful moment, we would like to welcome all of the speakers from Monash University, Australia, Central Escolar University, Philippines, Buriram Rajabat University, Thailand, and Yuanpei University of Medical Technology, Taiwan. Also, we would like to welcome to co-host partners, Akademi Kesehatan Rustida, Stikes Bakti Al-Qadiri, Fakultas Keperawatan Universitas Jember, Fakultas Ilmu Kesehatan Universitas Muhammadiyah Lamongan, Prodi D3 Keperawatan Universitas Bondowoso, and distinguished participants. Ladies and gentlemen, first, let's us pray and praise to Allah Subhanahu wa Ta'ala. Because of His bless and mercy, we can attend together in the International Scientific Meeting in Nursing 2021. Salawat and salam to our beloved Prophet Muhammad Sallallahu Alaihi Wasallam, who had brought us to the path of light and left the darkness in this life. The Honorable Dr. Hanafi, MPD, as a Rector of Universitas Muhammadiyah Jember. The Honorable Chairman of Regional Representative Council, Indonesia National Nursing Association. The Honorable Dean of Fikes Universitas Muhammadiyah Jember. Director of Akademi Kesehatan Rustida. Chairperson of Stikes Bakti Al-Qadiri. Dean of Fakultas Keperawatan Universitas Jember, Dean of Fakultas Ilmu Kesehatan Universitas Muhammadiyah Lamongan, Chairperson of Prodi D3 Keperawatan Universitas Bondowoso. Before we move to the next agenda, for all participants, please turn on your camera and keep your microphone off. Thank you. Ladies and gentlemen, on this nice occasion, let me deliver the structure of the event today as follows: opening remarks and pre-plenary session. Now we are entering the opening remarks. First, let's open this event by saying Basmalah. Bismillahirrahmanirrahim. Thank you. Second, let's listen Indonesia National Anthem, followed by Sang Surya Song. Thank you. The next session, Chair Committee Report, will be delivered by Nurse Dwi Yunita Haryanti, MKes. Time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. The Excellencies, Rector of Muhammadiyah University of Jember, the Dean of Health Science Department of Muhammadiyah University of Jember, the speakers of the International Scientific Meeting in Nursing, all the co-hosts and committee, and all participants of this program. Alhamdulillahi nahmaduhu wa nasta'inuhu wa nastaghfiruh wa na'udzu billahi min sururi anfusina wa min sayyiati a'malina may yahdihillahu fala mudilla lahu wa may yudlilhu fala hadiyalah. Asyhadu an la ilaha illallah wa asyhadu anna Muhammadan abduhu wa rasuluh la nabiyya ba'dah. Good morning and welcome to this virtual assembly by Healthy and Happy. May God bless us and Prophet Muhammad sallallahu alaihi wasallam lead us to the right pathway. Amin. The Excellencies, ladies and gentlemen, we welcome you to the International Scientific Meeting in Nursing with the topic, Role of Microbiota and Sustaining TB Services in the Pandemic Era. What can we do as a nurse? Launching from WHO website, this year's World TB Day has the theme, The Clock is Ticking. These themes confess that the world is running out of the time to act because of the commitment that TB is made by global leaders. This is in line with the context of COVID-19 pandemic, which is currently endemic throughout the world. WHO states that TB is the deadliest infectious disease in the world, and Indonesia includes to the 8 countries that account for 2/3 of TB cases worldwide, or the second rank after India, which has 845,000 cases with 98,000 deaths, or equivalent to 11 deaths per hour. Prevention is still better than curative. We are required to be able to find the right solution to overcome the spread of TB and increase the mortality rate due to TB. In this case, a comprehensive approach is needed to improve the health service system. Pandemic teach us to appreciate the healthness, both physically and psychologically. We all know that increasing a person's immunity and psychological status is the main key to stay healthy. This International Scientific Meeting in Nursing 2021 aims to improve the understanding and enhancing the knowledge about tropical infectious disease in the nursing area, especially in tuberculosis. This scientific meeting raised several issues, including tuberculosis infection in the COVID-19 pandemic era, updating in nursing care management of pulmonary tuberculosis, nursing guidance for managing side effects to drug resistance of TB treatment, complementary therapies in nursing, and the microbiota and its role in Mycobacterium tuberculosis infection. And our presenter on these 2 days come from 5 countries. We welcome to Mr. James Trower from Monash University, Australia. Also welcome to Ms. Pai Van Lin from UNP University of Medical Technology, Taiwan. Welcome to Ms. Yam Kongruangrat from Burirat Rajabat University, Thailand. Also welcome to Ms. Josephine De Leon from Central Escolar University, Philippines. And welcome to Mr. Hendra Kurniawan from Muhammadiyah University of Jember, Indonesia. This international scientific meeting in nursing also opened the wide opportunity for oral presentation participants to share the research result related to TB or anything that contribute to the TB treatment, especially in the era of COVID-19 pandemic. The Excellencies, ladies and gentlemen, this international scientific meeting in nursing was attended by health students, representative of health service and nurse organization, academic, health practitioner in clinic and communities, with a total of 650 participants, and also we selected 12 best articles for oral presentation. This event was help of the cooperation and extraordinary effort from the committees and co-hosts. Therefore, we would like to thank to the Dean of Health Science Faculty, Muhammadiyah University of Jember, the Dean of Health Science Faculty, Muhammadiyah University of Lamongan, the Dean of Nursing Faculty from Jember University, Bakti Al-Qadir School of Health, Rustida Health Academy, Banyuwangi, Bondowoso Nursing Academy, and the Indonesian National Nurse Association. On behalf of the host and the committee, I would like to extend our deepest appreciation to you all for your support and your participation. Hopefully, our knowledge about TB management, especially in the era of COVID-19 pandemic, will increase through this program. Finally, enjoy this international scientific meeting in nursing. May Allah bless us, protect us on healthness and happiness. Thanks, and Assalamualaikum warahmatullahi wabarakatuh.
Thank you. Next, Director of Universitas Muhammadiyah Jember, Dr. Hanafi MPD, will deliver opening speech and officially open this meeting. Time is yours.
Oke. Assalamualaikum warahmatullahi wabarakatuh. A'udzubillahi minasyaitonirrajim. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Wa bihi nasta'in. Ala kulli umurituna wadin wassalatu wassalamu ala asrafil mursalin wa ala alihi wa sahbihi ajma'in. Good morning, ladies and gentlemen. All praise is due to Allah, the Lord of the universe, for enabling us to meet together here even through by virtual meeting. Peace and salam be upon the glorious Prophet Muhammad, who has brought us from darkness into rahmatan lil alamin. In this occasion, I greet you, the honorable speakers from Monash University, Australia, Central Escolar University, Philippines, Bariram Ratchapat University, Thailand, Yanpi University of Medical Technology, and especially Muhammadiyah University of Jember. Besides that, I also thanks to some co-hosts in this case related to this event, namely Akademi Kesehatan Rustida, Fakultas Keperawatan Universitas Jember, and also Fikes Bakti Al-Qadiri, it is in Jember, Fikes Muhammadiyah Lamongan, and Akademi Keperawatan Univ Bondowoso, and also Akademi Kesehatan Kerikilan Banyuwangi. And especially I say thanks for the Dean of Fikes, Nurse Asmianto Eskap MKet, and also the leader of PPNI, in this case, Nurse Asro Joyowitono Eskap MSI. On behalf of the Organizing Committee of the International Online Nursing Conference entitled Role of Microbiota Sustaining TB Services in the Pandemic Era, What Can We Do as a Nurse? I would like to warmly welcome to all of you who have joined us for this scientific meeting, especially to all of the speakers. We all know that today's condition is not so nice because of the COVID-19. And now, especially in Indonesia, higher and higher related to the new victim of COVID. But be sure that we still can do something together with COVID. But of course, we have to be careful related to our safety. Ladies and gentlemen, the success of this meeting depends on your active contribution, and we believe it. All to facilitate a free and fruitful exchange of ideas, I would like to thank and congratulate to all the entire organizing committee who have been able to present greatly speaker today, who have been able to present. I believe all of you, all of your hard work will be paid off. At the end, as director of Muhammadiyah University, I open this one by saying Bismillahirrahmanirrahim. I officially open this International Scientific Meeting in Nursing 2021. At the end, thank you, and I think it's enough my speech. I hope everything ran well, and wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much.
Welcome.
Dear ladies and gentlemen, this is the end of opening ceremony of the International Scientific Meeting in Nursing 2021. Before we are going to the session, we would like to invite all the participants to turn on your camera to take a picture. Thank you. We will back in a minute for starting the plenary session. Announcement to all participants. Certificate will send to your email gradually in 1 week, as well as the certificate will give to those who join today's of the meeting by fill your data at the attendance list. To all participants, certificate will send to your email gradually in 1 week, as well as the certificate will give to those who join today's of the meeting by fill your data at the attendance list. Thank you. Thank you. This plenary session will be presented by amazing speaker from Monash University, Australia, Centro Escolar University, Philippines, and Buriram Rajabat University, Thailand. Now, we are going to begin our first plenary session. I would like to invite Nurse Anggia Astuti, SKP MKes, as a moderator in this session. Let me inform her curriculum vitae. She was born in Blitar, January 26, 1984, graduate of Diplomatry in Nursing, Polkesma Malang Prodi Blitar, 2005, Bachelor of Nursing, Binawan of Health Science Jakarta, 2007, Master of Nursing Universitas Erlangga Surabaya, 2017, and working experience as emergency staff nurse, King Faisal Hospital, KSA, 2007 to 2011, and lecture in School of Nursing, Faculty of Nursing, Jember University since 2011. For Ms. Anggita, time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning for Bapak Rektor, Vice Rector, Dean, Vice Dean, and Chairperson, dear all speakers and honorable all participants of this International Scientific Meeting in Nursing 2021, Faculty of Nursing, Muhammadiyah University of Jember. I am Anggia Astuti. It is a wonderful and very valuable opportunity for me to be your moderator for today's first session. First of all, I would like to tell you how this session will go. This session will guide 3 speakers. The first presentation will come from Mr. James Treasure from Monash University, Australia. Then we will do question and answer session is about 15 minutes. The session will continue with panel discussion of 2 oral presentation and Q&A session. Before we follow the great presentation from Mr. James Trevor, please allow me to deliver the rules of this session that need to be noted and told to all participants. All participants must have to stand by 15 minutes before the conference starts. Open the camera with mute mode and use the virtual background that have given by community. Rename your account with the following format: institution underscore name for conference participant, OP underscore name institution for oral presenter, post underscore name underscore institution for poster participant. Raise your hand and unmute if you want to ask after the moderator invites, or write your question in the chat room with format hashtag
Narsanggi, are you still here?
Yes, I'm so sorry. I was disconnected for a while. Can I continue?
Yes, please, Miss.
Okay, thank you very much. Maybe the committee will share screen about the attention, please. Okay, while waiting for share screen, I will continue the rule. Number 4, fill in the attendance link provided by the committee and follow the conference in orderly manner until the end. I see Mr. James have joined with us. Hello, Mr. James, how are you today? Hello, Mr. James, are you with us?
Yes, Thank you very much for having me. I wasn't able to unmute, but now I have. So yes, I'm here. Hello.
Okay, thank you. I wish you a healthy and happy day. Okay, please, I will continue the rules. And let's see, ladies and gentlemen. Now, allow me to welcome the speaker. He is Mr. James Terwer, Associate Professor. He is Associate Professor, Biostatistics Data Analytics, Modeling, and Health Economic Head of the Epidemiological Modeling Unit for the School of Public Health and Preventive Medicine at Monash University. Today, most of his research has focused on tuberculosis epidemiological, but has recently shifted its focus to include a strong interest in COVID-19 pandemic. He has a lot of projects between 2016 and 2023. There are real-time modeling of the COVID epidemic in Australia, the coronavirus in Victorian healthcare and aged care worker cohort study, improving global tuberculosis control with the Autumn platform, plotting a course of tuberculosis elimination in our lifetime, and his research output between 2008 till 2021 are time for a clear national COVID strategy. Timing of Mycobacterium tuberculosis exposure explain variation in BCG effectiveness, a systematic review, and meta-analysis. 3. Estimating long-term tuberculosis reaction rates in Australian migrants. Heterogeneous infectiousness in mathematical model of tuberculosis, a systematic review, and 68 more research output. Okay, ladies and gentlemen, Mr. James will make presentation about tuberculosis infection in COVID-19 pandemic era. Mr. Jember, you have 45 minutes to present your material. Are you going to share your own screen? I'm sorry,
Yes. Just unmuting. Yes, I'm just about to share my screen. Does that look correct to you?
Yes.
Yeah.
Present already.
Great. And you can hear me okay?
So, Mr. James. Yes, very clear. So, time is yours.
Thanks so much. Thanks so much for having me at this conference, and it's a pleasure to speak to you all. I guess, as mentioned, my research was mostly in tuberculosis epidemiology and control up until about 2 years ago, or just under 2 years ago, when the COVID-19 pandemic started. And I've shifted over to thinking a lot about COVID-19, which is clearly a very important issue for Indonesia and for our region at the moment. So in my 45 minutes, I'm going to divide the time between speaking first about COVID-19 and then moving towards speaking more about tuberculosis, and hopefully maintaining a clinical focus and some relevance to Indonesia and to the role of nurses within the control of these two very important infectious diseases. So I will just, try to advance my slides. There we go. So yeah, I'm going to start off thinking about COVID-19 a little, and I'll get into some of my own research, but I also wanted to introduce this paper that was published in Science a few weeks ago, a couple of months ago, and considers the longer term prospects for COVID-19. I think we're really in a major global crisis at the moment in relation to COVID-19. The Delta variant has really changed things considerably compared to last year. And I don't in any way mean to minimize the importance of COVID-19 at the moment. It's really a major crisis. And I think the next few months, we may well see some of the highest mortality rates in many countries around the world from COVID-19. And so it's quite a major crisis. It's quite a depressing situation to work in many ways. People are dying around the world. So just to put a slightly more positive spin on it, I think once we're through this crisis, we will hopefully have a more positive outlook after this. And I think this paper from Science shows this quite nicely. So we know that there are 4 coronaviruses, human coronaviruses that circulate in human populations, and they're endemic. So they circulate all year round. They tend to have seasonal peaks in winter. They essentially behave like the human common cold. And the pattern of infection is illustrated really, really nicely from this figure, I think. So just to explain this in a little bit more detail, there are 4 human endemic coronaviruses. 2 of them are alpha coronaviruses and 2 of them are beta coronaviruses like COVID-19. And they all behave fairly similarly. And what we have here on these plots are illustrations of the proportion of people with antibodies at different ages. So we have age along the horizontal axis, and we have the proportion of people with 2 different classes of antibodies on the vertical axis. And the purple antibodies are IgM antibodies, and IgM antibodies are produced immediately after infection, so they more reflect recent infection, and they show where the first time infection, and so they show what groups of people are being infected with these coronaviruses for the first time. The IgG antibodies are illustrated in the green dots, and they show what proportion of people really have ever been exposed. They do wane a little bit over time, but you can see that by a very young age, most people have been infected by these coronaviruses. So for all of the human endemic coronaviruses, the mean age at first infection is around 4 to 6 years. And you can imagine that if COVID begins to behave in this way, and if everybody's infected very early in their life, we would expect a very low mortality rate from this, because we know that the probability of dying as a result of being infected with COVID is very, very low in children. So the main problem, of course, with COVID is that we're still in a pandemic situation. So the virus is circulating in all age groups, and we have a lot of elderly people who are being infected with COVID for the first time. But this will change over time, and we're likely to see that transmission is increasingly concentrated within children. And we know also that for COVID-19, that immunity to infection, so complete immunity from developing disease, tends to wane over a relatively short period of time. And we know that you can get reinfected within months or maybe a year or 2 from your first exposure. But we think that protection against severe disease lasts longer than that. And that's the case for the human coronaviruses that are already circulating as well. So we have quite a similar pattern of immunity, and that's what favors people being infected for the first time in children in the case of the endemic coronaviruses. So if you look at so this is the infection fatality ratio for 3 coronaviruses, not the endemic ones, pandemic COVID-19, which is marked as COV2 here in red, MERS, which is a very concerning coronavirus that exists in camels in the Middle East, and COVID and SARS, SARS-CoV-1, which did not cause a pandemic in 2003. These all have quite different patterns in terms of their infection fatality ratio. The infection fatality ratio is the probability of dying given that you're infected with one of these viruses. And so in the case of SARS-CoV-1 and also in the case of SARS-CoV-2, we see that the probability of dying if you're young is very, very small, but it accelerates very markedly over time, over age. And you can see that in the oldest age groups, we get infection fatality ratios. I think this is relatively conservative. I think we can see in 80 years and above infection fatality ratios that are as high as 10 or 20%. So that's what leads to the pattern that I was describing. So what we might expect to see over the course of the coming years is that the infection fatality ratio, the probability of dying across a population, given that you're infected with COVID-19, will decline because we have more and more people who are infected in childhood when they're infected for the first time. And the elderly have already been exposed either through natural infection or they may have been vaccinated in reality. This particular modelling paper in Science assumed that immunity was built up only through natural infection, through circulation. And so if you look at the top panel here, again, red for COVID-19, you can see what we might expect to happen over the years from when COVID-19 first emerged. At the left-hand side, so the time on the horizontal axis is time from when COVID first emerges and then is allowed to cause substantial epidemics. And you can see that at the left extreme, as COVID's first emerging and it's circulating across the whole population, including the elderly and the younger groups, we have an infection fatality ratio somewhere around 8%. But with continued transmission, that steadily declines, and over 10 years, we might see that decline tenfold to 0.1%, which would make it a very different consideration and make it much more manageable. Now, as I mentioned, this particular model doesn't consider vaccination. It only considers transmission as building immunity. But I think vaccination is still, of course, very important. And it's sort of a shortcut in a way. If we can vaccinate the elderly and protect them from the very high risk of death with first infection, we can rapidly get ourselves across to this more favorable situation where most people have some level of immunity to the virus, and the people who are being exposed for the first time as COVID becomes endemic are largely children with a much lower infection fatality ratio. And we're already beginning to see that in some countries, particularly countries that have been successful with their vaccination programs, which unfortunately is mostly higher income settings at this time. But the UK experience is really very interesting, I think, in that what we are now seeing is a very large spike in cases in COVID-19 in the UK. We have about 40,000 cases per day recorded in the UK. That's quite similar to their previous wave, in which 40 to 50,000 cases were occurring per day. But you can see that the proportion of deaths is extraordinarily much lower in this wave than it was in the previous wave. So the UK are now getting about perhaps around 50 deaths per day, whereas they were getting more than 1,000 deaths per day in their previous wave. And the main distinction between those two waves is that now a large proportion of the population are vaccinated, whereas in the previous wave, that was not the case. So I think vaccination is a way to sort of take a shortcut towards getting closer to COVID behaving as more like an endemic circulating human coronavirus. And so I think in the longer term, we can be relatively positive about the likely outcomes, but it doesn't in any way take away from the fact that we desperately need to vaccinate large proportions of the population now to avoid those very high risks of death with a major epidemic wave. So I hope that made sense. That's sort of the good news first. And as I say, I don't want to downplay how major a global crisis this is at the moment. Looking more at the acute stage, this is a paper that we published in Lancet Regional Health Western Pacific, which looked at the COVID dynamics in the Philippines. We've been working closely with the Philippines Department of Health to assist them in their response and consider different epidemiological programmatic responses to COVID to try to reduce the impact of the epidemic. We used a mechanistic model. So a mechanistic model is one in which all of the population is divided into subgroups according to whether or not they've been exposed to the virus, have the virus currently, or have recovered from it. So if you look at panel B here, this is essentially before the model is elaborated and before we add a whole load of complexity in relation to age and other features. The base model is that people start off susceptible, they become exposed after infection, and then they progress through stages of infectiousness and clinical symptoms before eventually recovering. So this is called an SCIR framework, and it's a very commonly used framework in infectious diseases modeling. So we applied this to the Philippines, and one thing that we found very helpful in terms of applying the model was to incorporate estimates of mobility. And so panel E gives an example of this. And the mobility estimates that we use came from Google Mobility, which are publicly available and are quite useful to feed into the model. So we can consider that the transmission rates in various settings in the model scale with the estimates that are reported from Google Mobility. So as lockdowns come in, the transmission rates decline, and as those interventions are released, the transmission rates increase again. And we were able to capture the epidemic reasonably well, although we did need one more thing in order to capture it. So if we just implemented the model as I've described it, we actually didn't capture the epidemic. This is on a log scale, so it's a little bit difficult to imagine, but the data points are the black dots and the blue is the modeled estimate. And you can see that this model, without any further modifications, didn't really capture the epidemic very well. But we then implemented a process which we referred to as micro-distancing, which you can see illustrated here as the red line. And what this really did was to scale back the contact rates or the rates of interaction independent of the mobility data as the epidemic took off. And we got a much better fit. So this is now the blue model fit to the black data. And so essentially we were then able to fit the model to the data. And we did that at the national level in the top panel and for 3 regions. So to describe what I'm talking about a little bit more clearly, I think you can see here, this is where the epidemic is taking off between sort of May and August in the middle part of last year. And at that stage, the Philippines was becoming one of the most highly affected regions in the world. It had one of the highest case rates in the Asia Pacific and was recording more deaths than any other part of the Asia Pacific. But we would have expected to see an even more rapid increase given what we knew about COVID-19 and its dynamics. But if we assumed that this micro-distancing process came in through this time, then that really did slow the rate of takeoff, and we were able to get a much better picture of the epidemic. So I think that was really helpful. And we talked to the staff in the country about what might have been going on at this time, what was happening in the Philippines in the middle part of last year. And we had a very consistent message come back from the in-country staff in the Philippines that people had been increasingly adhering to interventions such as face covering use and hand hygiene and keeping physical distance between people. And that is why we refer to this function as micro-distancing. So that we consider this to be behavioral changes that took place in the middle part of last year in the Philippines that reduced the risk of transmission between people that wasn't captured through Google Mobility data. So Google Mobility data tells you about macro distancing, tells you whether people are going to the same places, but this function tells you about what people are doing when they're in those places. So we thought that those sorts of behavioral changes, physical distancing and face covering use, were very important in reducing the risk of transmission, the rates of transmission, and slowing the epidemic as it began to take off. So that was the experience of the Philippines. We did also, whenever you have a model like this, you want to validate it by considering whether it's consistent with other data sources. What I showed in the previous slide was the fit of the model to notification data, which in the Philippines was considered to be the most robust sort of source of data. It's often thought that mortality is perhaps the most robust indicator of the COVID epidemic, but the staff we were working with in the Philippines quite clearly told us that notifications were a more robust a more robust indicator of the epidemic size, because more effort was put into making sure that that data source was reliable by comparison to mortality that had quite a few issues associated with it. Here you see the comparison of the model fit to mortality data, and it actually does fit reasonably well, and that helps us to pin down a few of our model parameters and be more confident that our model is correct. And over the course of last year, we began to fit to ICU data as the epidemic wore on. But through much of last year, model projections were well over what was being reported in the Philippines. And the Philippines told us that the reason for that was that a number of ICUs only came on board with the data reporting to provide estimates at the national level for how many beds were occupied by COVID patients through the course of last year. And our model was very consistent with that description. So the other country that we've been working with is Malaysia. And I guess this is also another country that's very close to Indonesia, and so I think hopefully relevant and has some lessons for Indonesian control of COVID-19. So Malaysia had quite an interesting epidemic for much of last year. As you can see with this horizontal part of the line here, Malaysia had very, very good control of COVID-19 and very, very few cases. And at times their case numbers were so low that it may have even been possible for them to pursue more of an elimination approach, as has been adopted in Australia and New Zealand with varying degrees of success. However, there was continuing transmission in parts of the country that may have been under-recognised, and that included Sabah, which is a state that, of course, borders with Indonesia, and I guess towards the latter part of last year, it was recognised that there was significant transmission in Sabah, and then there was significant travel between Sabah and the rest of the country, and gradually an epidemic emerged, and a significant sized epidemic. So you can see this major wave that occurred right around the start of the year. And then also the wave then, there's been a resurgence over recent months as the Delta variant has begun to replace the wild type variant that was the wild type virus. And actually there was a lot of beta variant as well in Malaysia that was circulating prior to that time. So that's the situation that Malaysia is now in. We also fit our model to this epidemic, and I think again got a pretty good fit. You can see that there was a surge in cases, as I mentioned, around the start of the year, and again we used micro distancing. So we assumed that through contact tracing and personal protective behaviours like face covering use and hand hygiene, that the transmission rate declined sometime around February, March, and that was reflected in the declining case numbers. So that was enough for us to get a reasonably good fit of the first epidemic wave. But then as the new variants came through, we saw a substantial takeoff in transmission again. And it was essential for us to incorporate these new variants and consider that they were substantially more transmissible than the previous COVID that had been circulating in order to capture the epidemic. So clearly that's been a major issue for Malaysia, and their health service capacity is really very stretched at the moment as these cases increase. And at the same time, they're vaccinating large proportions of their population and hoping to get back to normality. So it's a very dynamic situation in that country at this time. I think one of the reasons why Malaysia was particularly at risk was because there'd been such good control last year. I think this also applies to countries like Vietnam, where there's been very good control last year. A very small proportion of the population have been exposed to COVID, which is very, very good, of course, that there's been good control. But it does also make the countries more susceptible to major outbreaks. So, I mean, these numbers there's a lot of variation in the model, and it's hard to have a very good, very precise estimate of exactly what proportion of the population has been exposed. But these are our estimates for Malaysia, and we think that probably no more than about sort of 5 to 10% of the overall adult population has been exposed to COVID, which is not enough to provide sort of substantial population immunity to protect against major outbreaks. And so that's a big part of the reason why we're now seeing a major outbreak. So having fit the model, I mean, we learned some lessons from that, but we also want to then be able to use this model for something and to plan programmatic responses and policy responses. And so we considered a range of scenarios in the case of Malaysia. So the blue line that you can see in all of these panels with different indicators is the baseline model fit to the indicators. And as I mentioned, I showed that previously, that we got a reasonable fit and felt that this was a good enough model to start thinking about what different programs might help to control the epidemic. And the first thing we looked at with the green and the purple lines was what might happen if we released all mobility restrictions and went back to normal. And essentially this is taking that Google mobility data, which you can see was well below the baseline level, and setting that back up to 100%. So we would consider that as allowing people who are working from home to go to on-site work, and for businesses to reopen and things like that. So we considered those two scenarios under two different vaccine coverage assumptions, and one was 50% coverage over 6 months and one was 80% coverage over 6 months. And you can see that if all mobility restrictions were released, we would project a huge epidemic. And as I mentioned, Malaysia is already having considerable trouble with its health services being close to capacity. And so you can see how enormous those curves are, that there is still a substantial risk of an enormous epidemic that would totally overwhelm all of the health services in that country. And you can also see between the green and the purple curves, there's not that much of a difference. So whether 50% vaccine coverage is achieved over the next 6 months or 80%, it doesn't actually make a huge difference to that epidemic. By contrast, if you consider what might happen if there's partial release of restrictions, a sort of a more cautious approach, if you look at the red and the brown curves, that considers allowing half of people who are working from home to go back to working on site, allowing half of businesses to reopen, then you can see that there's now a sort of a more significant difference between the red and the brown curves in terms of the size of the epidemic that's projected. And so if you maintain some restrictions on mobility while you roll out the vaccine program, there's the potential to significantly mitigate the size of the epidemic. Similarly, if you just allow a small amount of return to normal, if you compare the sort of tan color to the light blue color, there's again a much more controlled epidemic, and there's the potential to vaccinate people at a rate that would make a more meaningful difference to the number of people who are getting COVID, and that would save a lot of lives, potentially, thousands of lives by maintaining some restrictions on mobility, some of these programmatic lockdown measures while the vaccination program is being rolled out. So I think that's, so I think that this is another way of demonstrating this. So if you look at the top left panel, if we think about how important various parameters in our model are to determining the total number of incident cases that occur, you can see that if you look at the bottom panel, you can see that the vaccination program parameters actually don't make much of a difference. They're all clustered towards the bottom of the graph. So that indicates that if you do just release all your restrictions, actually the vaccination program becomes less important, because so many people have been infected before they've got a chance to be vaccinated. By contrast, if you look at the top two panels, where some mobility restrictions are maintained while the vaccination program is rolled out, there's a much bigger effect from the vaccination program parameters, like the efficacy and the coverage of the vaccine that's being used. And there's therefore the potential to save many lives by rolling out rapidly and efficiently an effective vaccine to protect people while some restrictions are maintained. So I think this sort of illustrates why it's such a key time in COVID epidemiology, that if we can just maintain some level of control of COVID over the coming months, then we have a much greater potential to save lives. So the next thing that I wanted to talk about is how we move towards TB elimination. So I'll finish up with COVID now. And I think I've got about maybe 10 to 15 minutes left to speak for, and talk about what the prospects are for TB elimination. I think TB elimination has been a very noble goal, and we're very good at setting global targets for TB elimination and control. But how we actually get there is a much more difficult point to work through. So let's think about that a little bit. And this is another example of a mechanistic model. So again, by mechanistic, we mean that it captures all of the mechanisms of infection transmission and people developing disease, and actually simulates the process by which people with disease infect other people. So one of the advantages of this sort of a model is that we can look at interventions at various stages through the cycle through the cascade of people becoming infected recently, then moving on to a sort of more mature stage of infection, developing active disease and recovering. So we can interrogate these models by saying what would happen if we did a specific thing around maybe case finding or treatment of latent infection. We've applied this model to a number of countries, and this is an example from our region of us applying it to the case of Fiji. We did a lot of different scenarios, and you can see that a lot of them didn't actually have a huge impact. Scenario 5 I've highlighted as being the active case finding intervention that, as you would expect, increases the number of notifications, so there's more people detected. But in terms of actually reducing the prevalence or the incidence of TB disease, it actually doesn't have a huge effect. And particularly in the case of Fiji, this is because a lot of the transmission, we believe, is driven by remote infection. So Fiji has a relatively low incidence rate of TB. And so there's not really that intense, there's no longer over the last couple of decades been that really intense transmission of TB. So just going out and finding the active cases won't have as much of an impact. Whereas what's driving these cases is people who have been infected quite some time ago, then still going on to reactivate and develop active disease. So again, I've tried to have a very regional approach to this, and this is work that I wasn't involved with, but I thought was a really nice study, a randomized controlled trial that took place in Vietnam that was run by investigators from Sydney and published in the New England Journal, so some people might be aware of it. And this considered how active case finding might work out in a somewhat higher burden setting, being a southern province of Vietnam called Cà Mau. And so what they did in this study was that they randomized subcommunes, which you can see here shaded in grey or a sort of a darker green grey there. They randomized them to either active screening or control. And the ones who went through active screening had this active case finding intervention applied. This is what the active case finding intervention looked like. So the 60 subcommunes that were randomized to active case finding went through every adult in that subcommune and asked them on each year about whether they had symptoms of TB and tested their sputum for TB, for Mycobacterium tuberculosis with the Gene Expert probe. So and then for a proportion also had chest X-ray. So this was repeated over the course of 4 years, and for the intervention clusters, they assessed for the intervention subcommunes, they assessed that subcommune each year, and so they did that active case finding, which was both the intervention but also a way of working out how many people had TB in that area. For the controls, they only screened them at the end of the 4-year period. And also for both of these groups of subcommunes, they tested young children to see whether their rates of infection had declined. So you might argue that this study is somewhat flawed because the control subcommunes or clusters could not be screened at year 1 or at year 0, and they were only screened at the end of the study. But the reason for that is because if they had been screened, there would have then been a responsibility for the investigators to actually treat the cases that they identified, and that would have essentially been active case finding as well. So in order for them to be a true control group, they had to ensure that those groups, that those regions, those subcommunes, weren't screened. So there is some uncertainty around what the rates of TB disease were in the control clusters at the start of the intervention. And this is what was seen. So you can see that over the course of the 4 years of the study being undertaken, that each year that fewer cases were identified in the intervention subcommunes, and in the control subcommunes at the end of the study, there was a much higher rate of TB than there was in the intervention. So we think that this intervention had an effect of reducing the rates of TB by about 50% from what they would have been otherwise. And so I think that's very encouraging that just even screening for active TB in a setting of some substantial transmission can clearly deliver results. What we don't know, of course, is what the control group were like at the start of the study and whether their rates also decreased over time. And so there may have been a secular trend in terms of the rates of disease, the rates of TB declining over the course of the 4 years of the study. We don't really know that. But we would suspect that from the fact that the control group had much lower rate of TB compared to the intervention group at the start. So I think I think these investigators were able to demonstrate good effective active case finding, not linked to latent TB infection treatment. So the last thing they looked at is what the rates of TB infection were in children who were within the intervention or the control groups, and they found that particularly for the children who were born more recently, is that correct? That there were significant declines. Yeah, I thought that was what they found, was that for the children born more recently, there were significant declines in rates of infection. I'd probably have to have another look at that. I'm not sure that's exactly what that graph shows, but that's what I understood it to show. So that study did show a substantial decline in the rates of TB as a result of active case finding, but it didn't eliminate TB and it didn't go close to achieving the goals that we've now set for ourselves at an international level. So how do we go that extra mile and try to actually really detect everybody with TB and push through to elimination? And as I described in the case of our modeling application to Fiji, the thing that limits us from being able to do that is this large pool of latent TB infection. And that's been estimated a number of years ago as being about 1/3 of the world's population, and a more recent estimate is that it may be around 25%, 1/4 of the world's population are infected with latent TB. So you can imagine that even if you had a magic intervention that identified everybody immediately they developed TB and prevented them from infecting anybody, you would still have this pool of latent infection that would continue to reactivate and seed the epidemic again. So it's likely that active case finding, as effective as it is not the whole solution and will not enable us to push through to elimination. So yeah, I'll just cover one more topic, which is thinking about latent TB reactivation rates. And this comes out of, I guess, reading the literature a number of years ago. We often hear this phrase, and you've probably heard it all yourselves as well, that the risk of developing active TB for people who have latent infection is 5 to 10% over the course of a lifetime. And half of that risk accrues in the years immediately following infection. And we did, I've probably got another slide about this later on, but we did a systematic review of this topic and were unable to find any evidence to support that statement. It's not to say that it's wrong, but it's now entirely unclear who first made this statement, what data it was based on, and why we should think that that is correct. It may be correct in certain groups, but I think it's often quite an unhelpful statement to say that overall the risk is 5 to 10% for anybody with latent TB infection, because I think if you look at individuals who are reactivating to TB, you can see really dramatic differences in the patterns and profiles of reactivation from infection to later getting active TB. We've looked at this a few times, and one way to look at this is through a survival analysis. So here people have followed over time to look at whether they get TB. And the particular group that we were looking at in this study is people who were contacts of active TB cases. And we divided this up by age. So in this figure, you can see that the blue shading is people aged under 5, children aged under 5. The grey shading is people aged 5 to 14. And the orange shading is people aged 15 and above. So that's the adult group. And the first thing you can see is that there's a huge difference by age in terms of your risk of reactivation, with children having a much, much higher risk than younger children, having a much, much higher risk than older children and than adults. And you can also see that for children, once they get through that initial high risk period, which goes for about 6 months.
Excuse me, Mr. Chen.
Yes.
We have more 5 minutes later.
Sure, thank you. Yes.
Okay.
Yeah, I'll probably finish up in 3 or 4 minutes. I'll just finish this section.
Okay, thank you.
No problem. So, so you can see that it's a very, very different profile. The children have a very, very high risk for it. Well, it's about 5 months after infection, and adults have a much lower risk in that early period, but then a much more sustained risk for years out from their original infection. Another way of looking at this is if you follow the people, so these are contacts that we identify in Victoria, our state within Australia, who have been exposed to active TB, and you look at their episodes of developing active TB, and you can see that so if you follow them from left to right, this is their time from exposure, and the vertical axis is their age at reactivation. And you can see, first of all, that there's a huge empty area here, which basically says that children who are first exposed very early in life have a very, very low risk until they reach adolescence. But then as they enter adolescence, their risk seems to increase again. So there's a few implications from a study like this. And I think one of them is that for children who are contacts of active TB, it's critical to detect them as early as possible. Try to get them, within a couple of months of their exposure, if possible, preferably within weeks, if that's possible, and treat them with preventive therapy to reduce their risk. If you don't get them in those first few months, then their risk is actually very low for the rest of childhood, likely until they progress into adolescence. Whereas adults, you can see that they continue to get episodes of active TB for years after their initial exposure. So I think this actually opens some windows to explore how we could achieve TB elimination more quickly. It means that, I guess it highlights some of the limitations of only identifying people through contact tracing of active TB cases. And I think this is something that I won't have time to speak about now, but we did do some modeling around trying to reach TB elimination in other parts of the world. And there are countries and settings where active case finding has been linked to TB elimination programs, and they are beginning to show some very promising results. And that's historically also been the case, that linking active case finding to treatment of active TB can have a substantial effect. So I think we need to do that, but we need to do that with an understanding of these quite distinct reactivation profiles for different age groups with time from exposure. And the other thing that this graph shows is how important BCG vaccination is to modifying the risk and how differently it works for different age groups. So I might finish up there. I think that should leave a bit of time for questions, and I'll hand back to the host.
Okay, thank you very much for sharing the great presentation today. This is nice presentation, Mr. James.
Thank
Okay,
you.
now, ladies and gentlemen, now are the time for the question and answer session. I would like to ask if there any lovely participant who wants to directly asking to Mr. James, please raise your hand and the committee will open your microphone. Okay, we have one, Mr. James, from Mr. Hendra Kurniawan. Time is yours.
Okay, thank you, Ibu Anggia. Good morning, Professor James.
Hi.
It's nice to meet you in this conference, actually.
You too.
And it's wonderful and also so much information that I get from your presentation. According to the slides that you presented just now about large-scale vaccination in Malaysia, right?
Yeah.
Just to share with you about the real situation in Indonesia, that we are Indonesian get two brands of the vaccine. I want to mention what is the brand name of the vaccine, but at least we get more than one brand in the vaccine in Indonesia. For brand one, from the first to the second vaccination, the time from the first to the second is 28 days, while the brand two is from the first vaccination to the second vaccination is 12 weeks. So it means there is a different time between the first and the second vaccination. So my question to you is about what is your perspective about the effectiveness of the vaccination in case of large-scale vaccination. As we know, here in Indonesia, the community is so large, so many people of Indonesia citizens. And could you explain about this and compare it with your country in Australia? Thank you.
Sure. Thanks very much for the question. And I mean, I guess very quickly, the first thing to say is that our model didn't really capture that. The model just considers that as people are vaccinated, they transition from being unvaccinated to vaccinated. And we didn't consider the complexity of the different vaccines, which in the real world is quite a very important consideration, of course. And the vaccines do have different characteristics, and the level of evidence that we have to support each one is quite variable, and they likely have different effects on different variants, although that's still emerging and it's not entirely clear. And it's also they have different effects after one dose from two. And these things are, they're very difficult to keep up with. And the last thing is the extent to which they protect just against severe disease, or the extent to which they protect against infection and provide sort of sterilizing immunity. So I think it's also very dependent on the local epidemiology. And if you have a situation, say like the Philippines, where transmission is sort of, there's substantial levels of transmission, of course, in the Philippines currently. But there's also substantial levels of community immunity. So there is protection in that sense, that you really need to, you sort of want to build up as much good immunity with high quality vaccines in that setting. Whereas in somewhere like Vietnam, where there's a huge epidemic that's just beginning to take off in an entirely unvaccinated population, that's quite a different situation as well, where you just want to try to get, I guess, first doses into vulnerable people as quickly as possible. So they're all really important considerations. And I think contrasting against Australia, I think in Australia we haven't diversified enough. We've had all of our eggs in very few baskets, and we've ended up with a limited supply of Pfizer and then also a greater supply of AstraZeneca, but the community's lost confidence in AstraZeneca. So maintaining community confidence and providing clear messages is actually just as important as understanding all the epidemiology as well. So yeah, they're quite general comments. I'm not sure whether they're specific enough to your question, but it is really quite a complicated field. But I think, and so I guess the most important thing is to just try to make sure that you maintain community engagement, trust, and public acceptance while you get as much vaccine into as many people as possible before a large epidemic occurs, so that people get vaccinated before their first exposure. I think that's really the main thing to keep our focus on at the moment.
Okay,
thank you,
Mr.
James.
James. Yes, Mr. Hendra, have you satisfied with the answer?
Yeah, thank you so much.
Okay, thank you. Mr. James, we're gonna move to the chat room. We have some questions. I think we have many questions here, but I want to choose some for you. The first question, it must be from Sister Dwi Yunita. I can read for you. First, are people with TB likely to be at increased risk of COVID-19 infection, illness, and death? And then what should health authorities do to provide sustainability of essential TB services during the COVID-19 pandemic? And what services can be leveraged across both the diseases? Thank you. Sorry, Mr. James. You want I read all the question or one by one?
Oh yeah, sorry, I'll respond to that question. If you can read them to me, that would be great, because I'm not able to speak and sort of follow all the questions at the same time. But I'm happy to respond to that question now.
Yes, okay.
Yeah. So, I mean, I think we have seen episodes of COVID and TB occurring together. I mean, probably that happens at a slightly higher rate than you would expect through random chance, but that's probably not the main issue. I think probably the main thing that we're observing is that the risk factors for COVID-19 infection and for TB infection overlap quite a lot. And I think some of the most consistent signals that we've seen in the case of COVID-19 are that it is more likely to affect people who live in high density situations in major cities, and also in temperate regions during winter. Those things seem to have been fairly consistent in causing higher rates of infection. And of course, some of those risk factors overlap with TB. So I guess things like urban slums will be, I think, at particularly high risk for both TB infection and for COVID-19 infection. So I think probably that's the biggest dynamic that draws the two processes together. And the main effect of the COVID-19 pandemic on TB has just been that we've really lost, I think, a lot of visibility of the TB epidemic, because we've seen, we've just not been able to detect as many cases as well. And we just don't know what's happening as well, because notification rates for TB have fallen considerably during the pandemic. And that is almost certainly not a reduction in TB incidence. It's almost certainly that people who get TB are not presenting for care. And of course, there's a lot of reasons for that. The health services are strained with COVID-19, and so they're not able to effectively detect and notify people with TB. And also people are avoiding presenting for conditions that they think might not be serious. So if you have a cough that's been going for a few weeks, and you're living in an Indonesian village and you're concerned about COVID-19, I guess you might not want to come to the local hospital. That might not be top of your priorities. So I think those are more the main processes that we've seen, rather than any sort of specific biological or immunological reason why you'd get both at the same time. I think it's more about risk factors converging and health services being strained.
Okay, thank you very much for clear answering. And we have one more, please. Mr. James from Mr. Ando Mangkuluhur. I will read the question. If it's true, the pandemic have long term, we never know until when and finally become the endemic. What the first concern of you to educate and convening civil society as public health about the situation? Because I have seen another countries in same situation could make their stability through all policy or make which one that's so difficult to happen in my country. Thank you.
Yeah, well, I mean, I think this is a really acute and urgent issue to discuss, because I guess, as I said in my presentation, I think the next 3 months are going to be just absolutely critical for a lot of countries. And I don't understand the Indonesian epidemic as well as I understand the epidemic in a number of other countries. But I think that Indonesia are having significant problems at the moment, and there's Delta circulation that that is causing a lot of problems. And so I think, I think it's just key that we educate people quite urgently, actually, about, and policymakers as well, about the need to really aggressively try to control the epidemic while we vaccinate people over the next few months. Because once we've got through that stage, I hope that a lot of countries can transition to that point that the UK is now at, that I think is a much more favorable position. I think COVID will be endemic indefinitely, but ultimately it may just behave like another one of these human endemic circulating coronaviruses, and it may not cause huge rates of disease in the longer term. So I think, we need to respond rapidly and urgently now, with an understanding that we will be able to get back to normal in the coming years. Relative normal.
Yes, okay. Okay, thank you, sir. And we have one more question from Ms. Alfianti Lutfi Shafika. The question is, how is an effective tuberculosis prevention series carried out, especially during the COVID-19 pandemic?
Yeah, well, that's a really good question. I mean, I think, I guess probably for the next few months, the best that we can do is just try to treat the most severely affected patients with TB, like the people who are presenting with really, significant TB disease. And I think probably health services do have to prioritize those sorts of activities. And it's hard to do things like outreach, as I described the programs in Vietnam, and also the program that we've been working with in the Marshall Islands, where they really went out comprehensively and tried to screen large population groups to identify people with TB infection and treat them to prevent them from getting TB. I think that sort of thing's just really, really difficult to do in the short term. But we can look, I think, hopefully in a year or two from now, things will have changed a lot if we have substantial vaccination coverage in a lot of countries. And also we've had substantial transmission, which has built natural immunity, and we should be planning to think about these things again soon.
Yes, okay, thank you very much. This is the last question for you. Now I can see you are really, really expert in the TB research, Mr. James, and I wish you be a professional, Professor James, in near time. Okay, thank you for your kindness. One more question, maybe?
Sure, yeah.
Yes, okay, thank you very much. The last question, it must from Sister Zahratul Zinani, Nur Farisha. When a TB patient is exposed to COVID-19, will the TB patient also experience the general symptoms of COVID-19? Thank you.
Yes, I think so. I guess is what we were discussing before, is that I think biologically and immunologically, I think we should essentially assume that the two conditions are pretty much independent, but it does have significant implications for health services. And I mean, and it also has implications which probably a lot of people on the call understand better than I understand. It has very important implications for how you actually go about testing somebody, because it's hard to test somebody for TB. Like, you need to get obviously a sputum specimen from them, but you need to do that in a way in which you have infection prevention set up appropriately. And in the case of COVID-19, you often might be considering both conditions as a possible diagnosis. And so the way in which you make sure you sort of exclude one and then move on to diagnosing the other while maintaining infection prevention, I think that's also been a really critical issue. And I think I guess a lot of the time, I think people have just got focused on COVID-19, understandably, which might be another reason for the lower rates of detection. So yeah, I think they're really tough issues, and I think for the next few months, COVID-19 is going to be more important than TB, and we just do have to focus on that and do the best with the resources and the resources we have.
Okay, thank you very much, Professor James Brewer. Okay,
Thank you.
I think all questions have been answered well, and I think actually we have more questions from the lovely participants, but I'm so sorry our time is limited. And if you follow me to make a small conclusion that the COVID-19 now are landing as pandemic in around the world, and then we have to change our rule behavior, like a face covering, hand washing, and safety space. And then this is more dangerous and this for TB patient. And I know your team, Professor James, will make this research upgrade more and more. Okay, before we close this first session for you, please give us the closing statement for this our nice presentation today. Okay, please, Professor James Brewer.
Yeah, so I mean, I guess when I was preparing my slides, I was originally focusing on TB because that was one of the themes of the conference, but I think we just have to be prepared for a really tough few months in COVID, and I think we have to be focused on COVID for the next few months, and vaccination is the way to protect people. And so the thing, yeah, we just need to get as many vaccines into people before they first get exposed to COVID across the world as we can.
Yes, thank you very much. Please give applause to our Professor James Brewer. He is the expert in TB research. Mr. James, please, I'm gonna inform to you that we are happy if you can stay, and we need you to stay till this session end, because we have still 2 oral presentation, and we will do the panel discussion. And please, in the end, please give them the review about the oral presentation that they make today. Okay? Now, I will call, please welcome with us Mr. Mashuri, Sarjana Keperawatan, Magister Keperawatan, from Diploma Nursing, Faculty of Nursing, University of Jember. He will present the early detection of cervical cancer with pap smear examination women tobacco farmers in Wuluhan district of Jember Regency. Mr. Mashuri, are you with us? Hello, Mr. Mashuri. I see you're still mute.
Hello, Mr. Sanggi.
Yes, okay, thank you very much. You are still with us. Okay, Mr. Mashuri, you have 7 minutes maximum to present your articles, and time is yours.
Yes, thank you very much, Mr. Anggi. Permission and share my research. What you looking, Mr. Sanggi?
Yes, it's performs. Okay. You can start now, Mr. Mashuri.
Okay, thank you, Mrs. Anggi. I sorry, Mrs. Anggi. This is my problem. Okay, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you opportunity ini. I am presentation for my research early detection of cervical cancer with pap smear examination on women tobacco farmers in Woluan district of Jember Regency. Yeah. Problem in cervical cancer is a gynecological malignancy that causes big problem in women health, especially in developing countries, especially in women who work in the agriculture sector, in the cultivation and processing of tobacco, who have a higher risk of being exposed to the use of chemicals such as pesticides that can cause increased level on cholestyrinase in the blood will trigger the growth of abnormal cell. And scala and scale, according to WHO IRC, International Agency for Research on Cancer in 2000, 2012, in women, new case of cervical cancer ranked after breast cancer and colorectal cancer, and also death from cervical cancer ranked for after breast cancer, colorectal cancer, and lung cancer. In Indonesia, every day there are 41 new cases of cervical cancer and 20 women died. So it is estimated that every hour a woman dies of cervical cancer. Okay, women will work if the tobacco farming sector has a higher risk of cervical cancer because in addicting to occupational factor, there are also other factors such as pattern of sexual intercourse, use of contraceptive, history of vaginal discharge with is suspected be due to either acute or chronic infection. Solution: early detection of cervical cancer with pap smear examination. Pap smear examination will be able to reduce the incident, and will improve the prognosis. Among other reduce the mortality rate. Pap smear is a simple way to detect cervical cancer, popular in the standard of examination for early detection of cervical cancer. So this method is the quick sample in developing countries in general and Indonesian in general in particular. There are still many obstacles to being able to do this pap test directly with the way of early detection of cervical cancer. Yeah. Definition: the cervical cancer, the cervix on the cervical in area of the female reproductive organ that is the entry to uterus, which located between the uterus and the intercourse health vagina. The pap smear is safe and inexpensive and has been used for many years to detect abnormality that occur in cervical epithelial cell. The test is the first time discovered by Papa Nicolau, hence the name pap smear test. Classification, Papa Nicolau classification according A, classification 1, no abnormal cell. And class 2, GR atypical cytology feature, but no indicated violent or malignant. And class 3, cytological feature, suspected of malignancy and mid to moderate dysplasia. And class 4, cytological picture for severe display. And class 5, malignancy. Okay. Yeah. This is chapter 3, research methods. Research method is descriptive explorative through the method of observational approach and location in Mulan district of Jember Regency. Time in June 2021. Sample 22 tobacco farmer. The requirement of the pap smear procedure, such as not having sex at last 48 hours before the examination. Data collection is for observation for cervical cytological examination with Papa Nicolau staining and classification of cytological examination. Statistic tests for my research that were analysis using univariate test. Okay. Result my research in the table 40.1, 4.1 frequency distribution of respondent pH. And my table, most respondents are in the age range of 30 and until 38 year, and many as 12 age respondent, and the last respondent in the age range 50 and 80 year, and many as respondent. And the table frequency, to table frequency distribution respondent by village of original, and distribution respondent by village in village temperature. I think for most of the respondent come from the village of temperature as many as 25 respondent, and the last respondent are from Luceter village, and as 2 respondent. And table 3 for 0.3 frequency distribution respondent by pap smear diagnosis. Based on the result of the pap smear diagnosis, most respondent with not specific chronic inflammation, we are 20 respondent, and the only one respondent choose pap smear diagnosis result. So an atrophic smear with non-specific chronic inflammation. And tab for 0.4 frequency distribution respondent by Papa Nicolau classification. Based on the papinuclear classification, there is one one respondent with plasmid showing class 3 cytological feature suspected of malignancy, mid to moderate dysplasia. Yes. Conclusion, based on the result, based on the result of the pap smear diagnosis, most respondents with non-specific chronic inflammation were 20 respondents. And based on the papinuclear classification, there is one respondent with pap smear result showing class 3 cytological feature and suspected of malignant, mild to moderate dysplasia. Yeah. Okay. Recommendation. Yeah. Recommendation for nurse in surface assessment can optimize the promotive and preventive role of cervical cancer in tobacco farming women church, reproductive health education, and early detection of cervical cancer with pap smear. For respondent, it has been recommended women tobacco farmer who have a high risk of cervical cancer always pay attention to their reproductive health by carrying out regular pap smear examination for early detection to prevent and overcome cervical cancer as early as possible. And for the next researcher, yes, it is hope of future research can identify other possible factors that cause cervical cancer risk in tobacco farming women, such as exposure to chemical in agricultural area from the planting process to the seeding process, with result in an increase in blood cholesterol level. Yes, thank you very much, Mrs. Anggi.
Okay, thank you very much, Mr. Masuri, for nice presentation. Dear all participants and Prof. James, sir, we have gone to move to the second oral presentation. Here we have Nas Suharyati, Sarjana Keperawatan Magister Keperawatan. To the second oral presentation. Here we have Nas Suharyati. The title is Keperawatan Magister Keperawatan. To the second oral presentation. Here we have and quality of life. Title is Keperawatan Magister Keperawatan. To the second oral presentation. Here we have and quality of life. Title is Keperawatan Magister Keperawatan. To the second oral presentation. Okay, Nas Suharyati, are you ready for nice presentation? Yes, I see you're still mute. Nas Suharyati, are you ready for nice presentation? Okay, while waiting Ms. Suharyati, please, dear all participants, if you have any question, please write your question in the chat room. Thank you. Please, dear all participants, if you have any question, please write your question in the chat room. Thank you. Please, dear all participants, if you have any question, please write your question in the chat room. Thank you. Please, dear all participants, if you have any question, please write your question in the chat room. Thank you. Please, dear all participants, if you have any question, please write your question in the chat room. Thank you. Please, dear all participants, if you have any question, please write your question in the chat room. Thank you. Please, dear all participants, if you have any question, please write your question in the chat room. Thank you. Okay, Ibu Suharyati, are you ready?
Halo, Assalamualaikum.
Yes. Waalaikumsalam warahmatullahi wabarakatuh. Okay. Suharyati, are you ready?
Ready? Halo, Assalamualaikum.
Yes. Waalaikumsalam
Iya.
warahmatullahi wabarakatuh. Okay. Suharyati, are you ready?
Ready? Halo, Assalamualaikum.
Yes. Waalaikumsalam
Iya.
warahmatullahi wabarakatuh. Okay. Suharyati, are you ready?
Ready? Halo, Assalamualaikum.
Yes. Waalaikumsalam
Iya.
warahmatullahi wabarakatuh. Okay. Suharyati, are you ready?
Ready? Assalamualaikum warahmatullahi wabarakatuh.
Iya.
Waalaikumsalam warahmatullahi wabarakatuh.
I am Suharyati from Universitas Muhammadiyah Lamongan. I will present my article and I am Suharyati from Universitas Muhammadiyah Lamongan. Tresor with oxygen present my article and COVID-19 patient. I am Suharyati from Universitas Muhammadiyah Lamongan. Tresor with oxygen present my article and COVID-19 patient. I am Suharyati from Universitas Muhammadiyah Lamongan. Tresor with oxygen present my article and COVID-19 patient. I am Suharyati from Universitas Muhammadiyah Lamongan. Tresor with oxygen present my article and COVID-19 patient. I am Suharyati from Universitas Muhammadiyah Lamongan.
Saturation level below 19% when entering hospital was a strong predictor of death. COVID-19 cases are increasing rapidly and spreading to the countries in a short time. Patients with symptomatic infection are quarantined in the hospital separated from other patients. Many COVID-19 patients are experiencing psychology problems during isolation and the hospital. Therefore, care environment in isolation room become external stressor for patients. Next. Okay. The result of the preliminary survey conducted Dr. Sugiri Hospital, 5 patients obtained 4 out of 5 patients, 80% were afraid. Medical record data showed patient saturation level of it was guided 90%. Obtained 3 out of 5 patients, 60% with good quality of life. Okay, next. Method, research design, correlation design. Participant and sampling, 59 respondent by purposive sampling in rumah sakit in Dr. Sugiri Hospital. Time data were read from March to May 2021. Variable, care environment stressor, oxygen saturation, and quality of life. Analyzing gamma and Summers test. Alpha equate 0.05. Next. Okay. Result, based on table 1, most of the respondents were female, 66.1%. A cat between 30 and 60 years, 69.55%. Were self-employment, 79.7%. Last education was elementary school, 37.3%. Source of transmission for other factor, 74.6%. And lack of treatment was for N7 day, 67.8%. Next. Next. Okay. Table 2 shown that care environment stressor related significant to oxygen saturation and patient quality of life. P less than 0.05. Oxygen saturation 0.022 and quality of life 0.035. Discussion. Patients come from different background and characteristics Indian, yet according to some source, patients who were isolated would experience anxiety. Most of the patients who experience anxiety were female because they tend to have higher anxiety level. Aside of the leading factor of anxiety was quarantined in isolation room. Next. During treatment in isolation room, respondents feel afraid and worried and suffer from insomnia. Most of the respondents were in critical condition, so that they need to treat in isolation room. Another research also revealed that is a new disease which threatens life. COVID-19 can cause substational anxiety and stress, especially the worst treated in isolation room. Next. Okay. Recent result showed that there was a relationship between can environment stressor with oxygen saturation. Isolation room can be an external stressor which is possible faced by COVID-19 patient. Anxiety and stress can change respiration rate and oxygen saturation in blood. Next. Okay. Results showed was a relationship between can environment stressor and quality of life. This is in line with the previous service which mentioned that environmental factor heavily affect quality of life. The respondent had good quality of life, although they are treated in isolation room. This follow research conducted by Yagar 2021, which showed that COVID-19 did not have a negative impact on quality of life in the short time. Okay, family support might increase quality of life of patients during isolation in the hospital. Thank you, Mr. Anggis.
Okay, thank you very much for nice presentation, Suharyati. Now we are on Q&A session. Please, we have one question and we'll do the panel session, okay? For Mrs. Suharyati, you have one question from Mr. Rudi Wibowo. I will read for you. What should people prepare at home to monitor oxygen saturation in case there is a member of the family get infected with COVID-19? Okay, time is yours. Okay, while waiting for Suharyati to answer the question, please, all participants, if you have any question, please, you can raise your hand or you can write the question in chat room. Okay, Suharyati, are you ready to answer? Suharyati. Excuse me, are you still with us? Excuse me, Miss Suharyati. Hello. Okay. While waiting, Miss Suharyati, please, Prof. James, do you have any question or any review for to our oral presentation today?
Or do I have any comments? No, I'm sorry. No, I wasn't quite aware we had the panel discussion, so I haven't really been making notes. I'm sorry.
Okay. The first title is about what is that? Early detection of cervical cancer with pap smear examination woman tobacco farmers. And the second one is the relationship between care environment stressor with oxygen saturation and quality of life of COVID-19 patients.
Oh yeah, sorry. I did hear some of the discussions, but I don't think I have anything very dramatic to add. I'm really sorry. I just they're not really my areas of expertise, and I think it's probably better that speakers themselves discuss on those points. Sorry.
Yes, okay, thank you, no problem. Maybe now our nurse Suharyati is ready for answering. Okay, Miss Suharyati. Oh, I think she is disconnect for this our plenary session. Okay, we will waiting. Or sorry, Miss Tia Ayu, are we have still the time for this plenary session? Maybe Mrs. Suharyati has bad connection today.
Yes, sorry for Miss Anggita. I think the time is up, so we should finish the first plenary session.
Okay. So I think it's time is up, and ladies and gentlemen, finally we come to the final agenda, and in this session, we extend our deepest gratitude to all speakers who have been willing to take the time to share knowledge and all experience to all of us. So to all participants from both country, Indonesia and out of Indonesia, to participate, we convey our highest consideration appreciation. We will end this session, and please, I apologize if I have any mistake for the session, and I really thanks so much for Mr. James Ferrer from Monash University, Australia.
Thank you.
I wish we can see each other in next time. Okay, ladies and gentlemen, when it's black, flip to white. When it's dark, flip it to white. For every mistake, flip it to forgiveness. Thank you very much for me, and see you next meeting. Wassalamualaikum warahmatullahi wabarakatuh. See you next, and I offer the floor back to the Mrs. Jihayu. Thank you very much.
Thank you. Thank you very much to the presenter, Mr. James from Monash University, Australia, and the moderator, Ms. Anggita. The first plenary session has delivered with excellent discussion. Now, we are going to begin our second plenary session. I would like to invite Ms. Eka Suryaning Tias as Kep MKes as a moderator in this session. Let me inform her curriculum vitae. She was born in Jember, January 31st, 1985. Graduate of Bachelor's Nursing Fikes Surya Global 2004 to 2008. Master of Health Universitas 11 Maret, Kedokteran Keluarga 2010 to 2012, Postgraduate Universitas Persada Indonesia in Clinical Psychology Program 2019 ongoing, and working experience as a lecturer and vice chairwoman of Fikes Bakti Al-Qadiri. For Ms. Eka, time is yours.
Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh. Good morning and best wishes to us all. First of all, let us pray and praise to our God because of His grace and mercy. We can attain together in this COVID pandemic condition here in the webinar role of microbiota and sustaining tuberculosis service in the pandemic era. When what can we do as a nurse? I hope all of the participants here in a good heart. Before I start this second session, allow me to introduce myself. First, my name is Eka Suryaning Tias, and I'm a lecturer in the Bachelor of Nursing program study, and now I'm here as the moderator of the second session. In this second session, I am the moderator of the speaker, Professor Josephine De Leon from Centro Escolar University, Philippines. Here I describe curriculum vitae. Professor Josephine M. De Leon as the Associate Professor as the Coordinator and Research Centro Escolar University. The work experience in 1990 to 1991 as the staff nurse Pascal General Hospital. In 1991 to 1992 as the OR nurse Our Lady of Spiritual Health Hospital. In 1992 to 1997 as the lecturer Our Lady of Fatima University. In 1997 to 2004 as the medical sales representative, distributor Pharma Diagnostica Philippines, and then in 2004 as the operating room nurse, Caution Doctor Hospital. In 2004 to 2006 as the clinical instructor Our Lady of Fatima University. In 2006 as the associate professor and coordinator for community and research. Next, research and publication, which are clinical profile of patient with type 2 diabetes mellitus in Manila, Philippines. Nursing intervention in the management of Filipino older persons. Evaluation of mobile and learning platform for nursing class. And then evaluation of student learning using case scenario approach. Experience of student using case scenario approach. Diabetes self-management education program among adolescents with
type 1 diabetes mellitus in Manila, Philippines. Effectiveness of propolis in preventing stroke, and then assessment of healthcare need of older person with type 2 diabetes mellitus, a learning, a spreadsheet of nursing lesson examination, the last academic and leisure performance of 2010-2012, graduate based of a purpose curriculum assessment. Okay, Professor Josephine will present a very special knowledge with the title Complementary Therapy in Nursing. For Professor Josephine, time is yours.
Sorry. Salamat Tetang. Salamat Pagi also. Okay. May I share my PowerPoint? Oh, sorry. Okay. Thank you very much, Ibu Eka. Is that? Okay. Thank you very much, Ibu Eka. So I am tasked to deliver today complementary therapy in this time of pandemic, specifically the role of nurses also in giving complementary therapy. Okay, so before we start, I am having as a simple or a short activity. So what word comes to your mind when you hear complementary therapy? Okay, so please kindly scan. Ibu Eka, please facilitate. Thank you. This is the link. You can also check the link from the chat room, and then you can also facilitate, and you can also answer. Okay, let's see. What are the different? Okay, sorry. I need to go to the slide though. Okay. Okay, everyone is answering? I hope everyone is answering. Let me see.
Coba sih. Orang buka nih aku cuy, lemot. Ini udah ya. Apa isinya?
Ibu Eka, is everyone answering? No? What's happening? Is there everyone answering? You can scan. Okay, wait a moment, Dr. De Leon. Okay. I think we're okay, so this join Slido. Okay, there's a result right now. Can you see the results? Okay, Ibu Eka, what does it mean? I don't know. Nice therapy, is that it? Okay, how about Beckham? What is
Yes.
Beckham?
Yes. I don't know. This is from Panitia.
Okay. Who else? Only 4 answered. Some more answers, please.
Okay.
I
What
think
comes to your mind
therapy
when you hear
bekam,
complementary therapy?
is cupping therapy, Dr. Josephine, I think.
Okay, that's Beckham. Okay,
Yes.
cupping therapy. Okay, other than? No more? Okay, so I hope other will participate also next time. I will share the slide. Though I don't know that this is new to you, so maybe we can start with the PowerPoint presentation, so I can start my discussion. Okay. Okay, so my objectives for today is to define complementary therapy. Okay, so number 2 is to discuss the different types of complementary therapy. Number 3 is to determine which complementary therapy is suitable for patients with tuberculosis. Number 4 is to present evidences on the effectiveness of complementary therapy in the treatment of tuberculosis and evaluate which is the best complementary therapy the nurse should advocate to patients. Now, we all know that we are in time of COVID pandemic, and a complementary therapy is important for us, specifically that we are not allowed to go out, that can cause cross-contamination or infection with COVID-19, and that may increase surge of cases of COVID-19. Okay, so before we go to the definition of complementary therapies, there are a lot of complementary therapies available, not only for tuberculosis, but also to other diseases or illnesses. Now we have acupuncture here, fatigue management, the use of the exercise, art and group therapy. We also have nutrition, diet, and even have the use of the herb or the traditional medicine. Okay, so let me define first what is a complementary and alternative therapy. Because when you say complementary, it comes also with the word as alternative therapy. Okay, complementary therapy is a term, according to the National Institute of Health, is a term of medical product and practices that are not part of a standard medical care. So when you say it's not part of a standard medical care, does doctor accept this kind of medical care to patients, specifically for patients with tuberculosis? Okay, so that's the question. And we need to find answers on this one, on this question, according to or depending on the guidelines or the evidences that is available for us. Okay, also, according to the Integrative Health and NCCIH, okay, when a non-mainstream practice is used together with conventional medicine, it is considered as complementary. So it is very definite that is in this definition that if a patient does not use a conventional medicine that is specifically for the treatment of tuberculosis or other illnesses, we can consider that as complementary. Okay? When also a non-mainstream practice is used instead of conventional medicine, it is considered as alternative. So that's the difference between complementary and alternative. In the complementary, the other treatment or other medications, such as complementary treatments or therapy, are used alongside with the standard or the conventional medicine or the treatment that is being given by the doctor. While in the alternative, these medications are not used anymore by the patients, maybe by his own will or by his own choice, and he uses a different conventional medicine, or instead of conventional medicine, he uses and considered alternative medicine. So that's a difference between the two. Okay, according to the NICE, or we called it as National Institute for Health and Care Excellence, complementary therapy provides guidance I'm sorry, the NICE provide guidance to the NIH, NHS, and effective treatments that are value for money. So meaning, uh, before a doctor or any practitioner would have to provide effective treatment to patients, they have to come up with a treatment, or they have to give treatment or advice to the patient based on the guidelines or the recommended recommendations. So the NICE has recommended the use of the COMS. COMS is the acronym for complementary and alternative medicines in a limited number of circumstances. So when you say limited number of circumstances, in a specific cases on a different illnesses, or on a specific patient, for example, they will have a different circumstances wherein they use complementary or alternative medicine. So for example of that is the Alexander technique for Parkinson's disease, the ginger and acupressure for reducing morning sickness, and manual therapy for lower back pain. Okay, so there are actually different types of complementary medicine. We have, I have shown you earlier the different types of complementary medicine, and this includes traditional alternative medicine, the touch, diet and herbs, external energy, mind, and the senses. Now, I want to discuss first a different type of complementary medicines for us to determine which of these complementary medicine is best for us to educate or to recommend to our patients with tuberculosis. Okay, let's start first with the traditional medicine, traditional alternative medicine, and this includes acupuncture, homeopathy, Ayurveda, naturopathy, Chinese or Oriental medicine. Okay, acupuncture is the practice of penetrating the skin with thin, solid metallic needles, which are then activated through gentle and specific movements of the practitioner's hands or with electrical stimulation. Acupuncture usually is to relieve discomfort associated with a variety of diseases, including pain, chemotherapy, to prevent induced nausea and vomiting. Okay. Another one is homeopathy. Homeopathy, also known as homeopathic medicine, is a medical system that was developed in Germany more than 200 years ago. It is based on two unconventional theories, like cures like law and the law of minimum dose. The notion that the lower dose of the medication achieved the greater effect. Many homeopathic products are so diluted so that no molecules of the original substance remain. Homeopathic products are often made as sugar pellets to be placed under the tongue. They may also be in other forms such as ointments, gels, drops, creams, and tablets. Treatments are usually individualized or tailored in each person. Ayurveda, on the other hand, is a natural system of medicine, which was originated in India more than 3,000 years ago. The term Ayurveda is derived from the Sanskrit words Ayur, which means life, and Veda, which means science of knowledge. Thus, Ayurveda translates to the knowledge of life. Ayurveda is based on the idea that disease is due to an imbalance or stress in a person's consciousness. Ayurveda encourages certain lifestyle intervention and natural therapies to regain balance between the body, mind, spirit, and the environment. Ayurveda treatment starts with an internal purification process followed by a special diet, herbal medicines, massage therapy, yoga, and meditation. The goal of the treatment aid the person by eliminating impurities, reducing symptoms, increasing resistance to disease, reducing worry, and increasing harmony in life. Herbs and other plants, including oils and common spices, are used extensively in Ayurvedic treatment. Next one is your naturopathy. Naturopathy, also called naturopathic medicine. Okay. Naturopathic medicine is a medical system that has evolved from a combination of traditional practices and healthcare approaches popular in Europe during the 19th century. Naturopathic practitioners use many different treatment approaches that includes dietary and lifestyle changes, stress reduction, herbs and other dietary supplements, homeopathy, manipulative therapies, exercise therapy, practitioner-guided detoxification, and psychotherapy and counseling. Then we also have the Chinese or Oriental medicine. Traditional Chinese medicine has evolved over thousands of years. TCM practitioners use various psychological and or physical approaches such as acupuncture and Tai Chi, as well as herbal products to address health problems. Traditional Chinese diagnostics are based on overall observation of human symptoms rather than micro level of laboratory tests. The methods for the Chinese medicine treatment includes acupuncture, Tai Chi, foot massage, massage therapy, Qigong, breathing and meditation exercises, physical exercises, Chinese martial arts, and the mental health therapy such as Feng Shui and Chinese astrology. Other complementary therapy includes touch. Healing touch by touching is based on the idea that illness or injury in one area of the body can affect all parts of the body. With the manual manipulation, the other parts can be brought back to optimum health. The body can fully focus on healing at the site of injury or illness. We also have chiropractic and osteopathic therapy. For chiropractic and osteopathic therapy, chiropractic deals primarily with special manipulation compared to osteopathic therapy, which primarily treats the musculoskeletal system of the body. Osteopathic physicians utilize many modern methods of medical care, such as providing prescriptions and surgery. They also used or offer manipulative medicine. The overall philosophy focuses on helping patients achieve wellness through the primary focal points of the prevention of disease whenever possible and the maintenance of a healthy lifestyle. While chiropractic, on the other hand, employs such as electrical stimulation, physiotherapy, soft tissue mobilization, and joint adjustment. Okay, we have mentioned about touch, and part of this touch is also what you call this massage or massage therapy. And massage have been tested as a complementary therapy as the practice of rubbing and kneading the body using the hands. We also have different exercises as part of the complementary therapy that includes body movements or dance therapy. It uses movement to help a person deal with an illness, a disability, or life challenges that keep them from functioning fully. The aim of the movement therapy is to enhance the person's cognitive, physical, mental, and emotional well-being. Example of these other exercises that is included in the complementary therapy is Tai Chi. Tai Chi is an ancient Chinese tradition that today is practiced as a graceful form of exercise. It involves a series of movements performed in a slow, focused manner and accompanied by deep breathing. The purpose of Tai Chi can help maintain strength, flexibility, and balance that is perfect to maintain activity for the rest of your life. Another one is yoga. Yoga is the use of yoga postures, meditation, and pranayama to help the body naturally heal and balance itself. Diet and herbs are also considered as complementary therapy. Diet and herbs can help you lose weight safely and more easily. The doctor also used dietary supplements as a complementary therapy, specifically to other illnesses and to uh, also for tuberculosis. Dietary supplements, in part as products taken by mouth that contain a dietary ingredient. Dietary ingredients that include vitamins and minerals and amino acids. Herbal medicines, on the other hand, are products from botanicals or plants that are used to treat diseases or to maintain health. And they are called herbal products or botanical products or phytomedicines. Okay. Other complementary therapies include external energy. So external energies from objects or other sources directly affect a person's health. And this includes electromagnetic therapy, Reiki therapy, and Qigong therapy. Electromagnetic therapy, sometimes referred to as pulse electromagnetic field or PEMF therapy, uses bursts of low-level electromagnetic radiation to target damaged tissue, relieve pain, or stimulate organs. While Reiki therapy, on the other hand, is a spiritual healing art with its roots in Japanese origin. The word Reiki comes from the Japanese word rei, which means universal life, and ki, which means energy. Actually, we have done, or we have a student, an undergraduate research, who have tested the effectiveness of Reiki therapy. Not specific for tuberculosis, but I think this is specific for hypertension. And they found out that Reiki therapy can, the exercise itself or the therapy itself can decrease or can improve blood pressure of patients with hypertension. We also have Qigong exercises. I think Qigong is a part of our research that we did for elderly persons when we implement a what do you call that, a a, uh, a nursing intervention to prevent frailty among older persons. And this Qigong exercise is a part of a package that we gave to these elderly persons in Manila. We target elderly persons in Manila, and we found out that the frailty level status or the symptoms that relates to frailty are decreased or prevented when they have they when they have done or participated in the nursing intervention that includes Qigong exercise. Now, what is Qigong about as complementary therapy? This is sometimes spelled as Qigong and pronounced Qigong in the study and practice of cultivating vital life force through the different various techniques, including breathing exercises and the postures. Okay, other than that, you have the exercise, the herbs, the nutrition, and the touch therapy, the mind. We also use the use of the mind or the mind therapy, okay, as a complementary medicine or a complementary therapy for different illnesses. So even standard or conventional medicine recognizes the power of the connection between the mind and the body. Studies have found that people heal better if they have good emotional and mental health. And examples of this mind therapy includes meditation, biofeedback, and hypnosis. We also know that these mind therapy also are effective in specific illnesses, specifically in psychiatry, nursing, or psychiatric illnesses. Okay, we also use the use of the senses. Some people believe the senses, such as the touch, the sight, the hearing, the smell, and the taste, can really affect overall health. Of course, it's a holistic, right? When a person is ill, all of the body parts are affected. And in terms of senses, as complementary medicine, the use of the art, the dance, and the music therapy. And we all know that music, there are a lot of studies around music therapy and dance therapy, specifically art therapy. And art therapy is mostly used for psychiatric illnesses also. Music therapy has been used in preventing pain for many researches. And this is considered as complementary therapy. We also have visualization as an example of senses, the use of sense therapy or the senses, and the guided imagery. I think the guided imagery has been used in many studies to lessen the pain, okay, of post-operative or uh, those who will undergo surgery. Okay, and then of course the visualization is also effective therapy. Okay. Okay, so what do you think is the most complementary therapy that I have discussed is suitable for patients with tuberculosis? Okay, we skip this one because you maybe you can if you want to answer, I'll stop first.
Yes,
Then
we want to answer your question.
okay, yeah, sure.
You can send.
Okay, you can you can scan.
How? Okay.
You can scan it with your phone.
Okay, I do, Miss.
Okay, can you do it? Ibu Eka, is it functioning? Okay, everybody has scanned already, so may I stop? And then I'll share also the link. Okay, I'll share the link also. Where is the chat room? Okay, this one. Okay, so this is the link also. Okay, let us see the okay, let me have this first down. I cannot see. Okay, let us see the results. Okay, so number one, they said 3 of the participants says nutrition, homeopathy, 2, and then yoga. Other participants, only 3 to 1. Okay, only 4 who participated. But anyway, nutrition, homeopathy, and yoga comes in. And we also have, okay, so it means that therapy and nutrition and exercise therapy is, I think, important for Indonesians. Okay, so maybe that's why. Yes, it is correct. Okay, may I go back now? But let me continue my presentation so we can answer my question. Okay, so this is my question, my presentation. Okay, so what would be the complementary therapy that is suitable for tuberculosis? Some complementary and alternative therapy treatments may be useful as supportive therapies. Now, there are studies that says that, or it is based on guidelines that a patient with tuberculosis should follow the treatment. Okay, they should not fail in taking the treatment provided for the tuberculosis treatment. Okay, we all know that tuberculosis treatment, they need to follow that and they need to complete that in order for them to be considered as cured for tuberculosis. TB should also be not be treated with alternative therapies alone. So meaning patient may not choose alternative therapies alone. Okay, they may use complementary therapies, but they should, okay, they should, let me emphasize that, they should follow the treatment and the medical regimen given for tuberculosis, and that includes anti-tuberculosis treatment. Okay, to cure the disease and avoid spreading it, they must be treated with prescription medications. Some complementary and alternative therapies may be useful only for or as supportive therapies. Okay, so based on your answers, nutrition comes in number 1, which is correct. Okay, so I think most of you are nurses, so you know what is the factor or what is the reason or what is the role of nutrition, okay, to patients with homeo or with tuberculosis. Okay, homeopathy is also another one. Okay, I think this also comes in the ranking. We also have herbs and acupuncture. Okay, so we all know that nutrition plays a vital role in management of patients with tuberculosis. So if we will be giving health education to our students, to our patients with tuberculosis, we have to educate them accordingly to this nutrition guidelines for them to have an effective treatment for tuberculosis. Number 1, they should of course eliminate all suspected food allergens that includes dairy products.
I'm
Okay,
sorry,
so
Professor Josephine. The
how many
time
minutes?
yeah, 5 minutes again.
5 minutes, no?
Yes.
Okay, I'll try. Okay, then vitamins and minerals, coffee and stimulants. Okay, we also use taking supplements or multivitamins, specifically your B complex vitamin, if you remember, that you really need this to prevent complications or uh, s- complications or of the medications that you take for anti-TB. And then there are studies also that includes vitamin D, okay, as complementary therapy for tuberculosis, and then the famous resveratrol, which is also famous for uh, for anti-COVID, and of course your anti-oxidants vitamins. Okay. We also have herbs for tuberculosis. Some of this one includes garlic, astragalus, and rhodiola. Okay. Homeopathy for tuberculosis includes medications or herbs rather, such as Arsenicum album and Calceria carbonica. So this is particularly for chest pain, specifically in patients with tuberculosis, and Calceria carbonica for chills or drowsiness or perspiration. Okay, do we have evidences regarding this one? Now, I gathered researches and studies that includes evidences. Okay, in the study of Adnan and Ali and Ambar in 2019, they review scattered literature on ethnomedicinal plants used to treat pneumonia and tuberculosis. And they found out that Acalpa indica L is the most inhibiting potential against Mycobacterium tuberculosis. This is considered as an ethnomedicinal plants or herbs. Okay, another study from Zhang et al. In 2020 includes or provide evidence about Kinbudan tablet. Okay, so Kinbudan tablet is an adjunct therapy for the treatment of PTP. Okay, so this Kimbudan tablet is a traditional Chinese medicine. So, however, in this study, they found out no significant improvement in the culture conversion of patients with retreatment PTB with traditional Chinese medication. However, on persons with adjunct therapy or QBDT as an adjunct therapy significantly promoted lesion absorption. In the study of Lee et al. In 2020, evaluated differences between traditional Chinese medicine from those of Western medication. And he found out that indicators include sputum smear negative rate or focus observation rate. He found out that traditional Chinese medication decoction combined with Western medication chemotherapy improve in comparison with those of the control group. Okay, don't worry, I still have a few slides more. Okay, then Kurniata and Kiranasari in 2018, I think this one is Indonesia, no, I'm sorry. Okay, they compare antimicrobacterial activity of 5 selected Indonesian indigenous medicinal plants. And they found out that among of these medicinal plants, all extract of 5 selected plants showed inhibited activity against Mycobacterium tuberculosis strain. Okay, lastly, we have another one by Prasetya et al. Also in Indonesia. He utilized, or the author utilized a efficacy or proved the efficacy of hypnosis in improving adherence to anti-tuberculosis treatment using the health belief model. And he found out that hypnotherapy had a positive effect and on perceived susceptibility, seriousness, threat, benefit, and self-efficacy. Also, Bisweswaria and Teles in 2004 compared the efficacy of anti-tuberculosis treatment. Okay, this is the use of yoga, and they found out there is a showed reduction in symptom scores. Okay, so in summary, what are the roles of nurses? I have more. Ibu Eka, please bear with me. 2 more slides to go. Okay, so what is the role of the nurses in complementary and alternative medication? Nurses need to understand all aspects of COM, including cause, patient knowledge, and drug interactions. If they are to promote holistic strategies for patients seeking to achieve a higher quality of life, that is according to Fowler and Newton. Nurses should also be familiar with the types of complementary therapy used most commonly in the professional setting, because they must have knowledge and their potential. They have to do health teaching process. It is also useful for nurses to know where to obtain information. So this includes guidelines and evidences for them to effectively recommend specific therapies. Nurses also need to understand all aspects of COM, including cause, patient's knowledge, and drug interactions, if they are to promote holistic strategies for patients seeking to achieve a higher quality of life. Lastly, let me conclude my presentation. There is a lack of research-based evidence for each therapy. This may create problems for inclusion in clinical practice. So in other words, the conventional medical medicine does not recommend complementary therapies because of lack of research-based evidence for different therapies. No COM therapy can be used alone for the treatment of TB. So if the patient want to utilize complementary therapy, they can use it as long as it is safe for them, but it cannot be used alone. It should come with the conventional medication, which is the anti-TB drugs. Lastly, careful evaluation must be considered by the nurse to understand COM and evaluate its effects to patients with tuberculosis. Terima kasih.
You are welcome. Terima kasih. Okay, thank you for the presentation. That is so interesting, the topic and material presented by Professor Josephine. It gives us more knowledge about complementary, so that it makes us more interested in discussing. Of course, it's us enough to just listen to the material. Therefore, we continue with the discussion session. For all the audience, I will give chance to ask directly 2 maximal questions for the first session. Please,
Okay,
the
Ibu,
participants.
Eka.
Yes.
I think I am older than you, but I call you Ibu.
Please, the participant write question in the chat box. Later, the comic will choose the question to be asked.
I'm sorry,
Okay.
Mrs. Eka. Can I ask something to Prof. De Leon?
Okay.
Yes. While waiting for the question for participants, allow one direct question. Please ask by activating video and audio.
Okay, thank you, Miss Eka. Hello, Dr. De Leon. Sorry, can I call you Miss De Leon or Prof. De
Joe.
Leon?
You can call me Joe.
Nice to meet you. Oh, okay. Nice to meet you. Welcome to Universitas Muhammadiyah Jember, Miss. Welcome to Indonesia.
I've been to Indonesia a lot of times.
Okay, thank you. It's nice to meet you. Maybe I will ask to you how complementary therapy practice in patient with TB. Maybe you can share to us in your country, especially in Philippines, maybe any collaborations between doctor, therapist, and nurse, maybe like that.
Okay.
Thank you.
Thank you for that
Thank you, Miss.
question, Miss Siri. Is that Siri? Okay. In the Philippine setting, we actually refer to our patient's treatment for tuberculosis based on our Department of Health. Okay. So that's like I guess in Indonesia that you have the conventional medication for TB, and that is the rifampicin and the package, right? You have the package. But in terms of complementary therapy, we do not practice actually here complementary therapy professionally. So when you speak of complementary therapy, the Department of Health only allows these herbs. Okay, only herbs is approved here, as they call it as halamang gamot. Okay, so herbs in Tagalog it's halamang gamot. So the herbs can be used as a complementary therapy for TB, specifically for different symptoms um, like we have the use of sambong, the use of sambong is a different one, not for TB. The use of, I forgot already, the one for cough. Okay, we have herbs specifically for cough, so they can use that, but that is a complementary. So only symptoms is relieved, only symptoms is improved, but they are not treated with TB. We don't have TB medications or complementary therapy for TB as of now. Okay, and in terms naman sa COVID, in terms of COVID, as of now they tried as complementary medicine is they tried the fish oil. I actually tried it, but unfortunately because of my age, my cholesterol increases. So it increased. So I guess it proves the evidence that before you use any complementary therapy, you have to check it with your doctor because it has to be a case-to-case basis. Thank you. I hope I answer your question.
Thank you,
Okay, thank
Professor
you.
Josephine. As well, question from Mrs. Sriwahyuni. Mrs. Sriwahyuni, have you satisfied the answer?
Okay, Miss Eka, I think enough.
Yes, thank you.
Thank you, Miss Josephine.
Okay, thank you. Thank you,
Indonesia
Ibu.
health is a favorite too.
Thank you, Miss Eka. Okay.
The next question, that is Ibu Yese Ayesi. Please open the mic. Ibu Ayesi.
Yes. Okay, thank you, Miss Eka, for the change.
I cannot hear you. Please.
Hello. Hello.
ISC, yes, Ibu,
Yes.
ISC.
Yes, Ayesi.
Yes, ISC. Hello, Miss Josephine. Nice to meet you.
Yes, nice to meet you too.
My question is, as we know, currently we are facing the COVID-19 pandemic. From the several complementary therapies that you explained, in your opinion, which therapy that has quick response to increase the immune system, particularly for patients with COVID-19 and TB comorbid, maybe? Okay, I
Okay,
think.
in my opinion, since we are now in COVID, the best therapy, complementary therapy that every patient can use, or that we as nurses can advocate to our patients with TB or with tuberculosis, is number one. You are correct with the ranking that you've done. Nutrition plays very important. Okay, why? Because it is where what we eat, and based on researches or based on studies, patients who had more uh, fish oil, or what do you call this one, omega oil, something like that, or high in cholesterol, are more prone to have tuberculosis. Of course, it has to undergo evidences. You still have to check the evidences. But then and again, as I have said before, that, or based on the guidelines, that nutrition really plays a vital role in the treatment process, right? Because we are what we eat, actually. We are what we eat. I'll give you my example. I don't, myself as an example, I don't have tuberculosis, of course, but I am 52 years old. I am sick with hypertension since 2003, I think. So that's 2 decades ago already. I mean, 2 decades already. And my cholesterol, because of the pandemic, my cholesterol, my uric acid has gone up. Okay, my liver test is worse because when I try to check my parameters, it's not good. So when I try to improve my nutrition, I eat less of pork, I eat less of this one and this one and this one. What happened now? It improves my health. So it's the same in all illnesses, not only tuberculosis. And since in TB and also in COVID, we have to improve our immunity. Okay, we have to improve our immune system so we can fight the virus and we can fight the the mycobacterium, the TB bacteria. Okay, thank you. I hope I answer your questions.
Okay, thank you, Professor Josephine. Next, there is a question from the chat box. I will read it. From Mrs. Susanti, how far the role of nurses in the complementary therapy? Thank you.
Again, Ibu Eka, what is the role?
How far the role?
Okay, how far?
Yes.
How far is the role of the nurses in complementary therapy?
Yes.
Okay, as nurse, number one of our function or role is to educate our patients, right? Okay, and we can be advocate also. So we can advocate specific complementary therapy. But as a nurse, you must be knowledgeable enough and you must be cautious in selecting different complementary therapies because we all know, and based on my presentation, complementary therapies will depend on case-to-case or individual patient's basis, meaning before you educate your patient, before you advocate a specific complementary therapy, you have to check it first, okay? Based on your guidelines, based on the recommendations. So research studies or evidence-based researches or guidelines are very important. And that is the role of the nurse. We have to educate people. And one thing more and very important is, since it is complementary therapy, as I have emphasized before and presented before, that patient must not, okay, must not forget to take the conventional medication or the treatment for TB, anti-TB treatment. Okay, thank
Yes.
you.
Thank you, Prof. Josephine. This very interesting answer. The next question from the chat box, I will read. From Resti Utami, the question is, how are the regulations for implementing complementary therapy in Philippines? Are there a special institution that provide license for complementary therapy professionals?
Okay, that's a good question. Actually, we have everyone has the FDA, right? Just like the COVID vaccine, it is regulated by the FDA, right? The Drug Regulatory Board. Okay, so we also have that in the Philippines. So for complementary therapy, as I have said before, that only the Department of Health, we only advocate or we only utilize complementary therapy that is endorsed by our Department of Health in the Philippines. Now, in terms of professional licensing, I cannot remember in the Professional Regulation Commission, we have the PRC. It is not yet included as professional. But as I have read with this presentation, that in the United States, they have complementary therapists and they are licensed for that. They are educated for that. In the Philippines, we don't have that because licensing includes education and training and practice. So we don't have. Thank
Okay,
you.
thank you. Let me read the last question from Jusmiana. The question is, between complementary and alternative, which one is better in case COVID-19 and tuberculosis? Or both can be used depending on the severity or other factors?
Okay, so let me answer that one by one. Between
Yes.
between complementary and alternative therapy, which is better? Before we go to COVID and TB, okay? As I have presented before earlier, that complementary therapy is different from alternative therapy because complementary, the word itself, complement the present medication. So it goes hand in hand at the same time or simultaneously with the patient taking the conventional medication or treatment for a specific disease, whether it's COVID or whether it's tuberculosis. Okay. Now, so if you ask me which of the two is effective or better in complementary in terms of COVID and what do you call this one in tuberculosis, okay? As I am talking about earlier, that the best or the evidence pa rin, the best evidence, there are no such evidence that this complementary therapy or this complementary therapy is better or effective in treating specific disease. So the best, I think they are praying already.
Yes.
Okay, the best question or the best answer for that is patient must be taking the conventional medicine. If they want to add complementary, then it's okay. But it has to be a case-to-case basis. So the same thing with COVID-19. If you have difficulty of breathing, will you have to undergo complementary therapy? It's not, right? Because this complementary therapy cannot treat your difficulty of breathing in COVID. The same thing with tuberculosis. If you if you fail to have your treatment and you go into the difficulty of breathing, your complementary therapy cannot cannot treat you with this one. Okay, so very important is to, as a nurse, is to consider, okay, to consider that the conventional medicine is still, although I agree with you that during this time of pandemic, complementary therapy may aid in the process of preventing, in the process of limiting symptoms or lessening symptoms of COVID and tuberculosis. Then you can use it. Okay?
Okay, thank you,
Thank you.
Josephine.
Assalamualaikum.
Waalaikumsalam.
Terima kasih.
Terima kasih. I'm sorry, let us listening azan duhur.
Already praying. Sorry.
Yes. Okay, Professor Josephine, we will have 2 oral presenters, and please don't leave the room since we need your valuable advice. Thank you.
Okay.
The next session is an oral presentation. I will read the participant and presentation material in this second session. The first, Miss Isni Lailatul Makfiro from Halal Faculty, Muhammadiyah University, Lamongan, with the title Palliative Care Based on Family Center Nursing Affect the Level of Dependency of the Patient Undergoing Hemodialysis. And the second, Ms. Dia Eko Martini from Health Faculty, Muhammadiyah University, Lamongan, with the title Determinant of Iron Supplementation Adherence Among Pregnant Women at Puskesmas Sugio, Lamongan. Okay. The first participant of oral presentation, Ms. Isni Lailatul Makfiro. Time is yours.
Okay, thank you. Can you hear my voice? Moderator? Okay. Okay, Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Thank you, moderator, for the time. I am Isni Lailatul Maghfiro from Universitas Muhammadiyah Lamongan, and here I will presenting about our research. Let me share my presentation. Okay. Can you see my presentation? Hello? Can you see my presentation here?
Yes.
Oh, okay, thank you. Okay, before I explain about the presentation, I will introduce my team or our team. This is our team, Miss Virjanti and Miss Trijati Me, Isni, Miss Rizky Asta, and Miss Aprilia. And our presentation about palliative care based on family-centered nursing affect the level of dependency of the patient undergoing hemodialysis. Okay, the background of this topic is about hemodialysis is a burdensome and complex therapy that cause physical and psychological stress. It can impact on the patient level of dependence in the patient's dialysis activities. Okay, we know that patients with chronic kidney disease will need hemodialysis during their life. And after being hospitalized, the majority of people with chronic kidney disease will return home to live with their families. So it requires a lot of support from the family. Patients will rely on their family to undergo treatment, therapy, and fulfill their daily needs. But the majority of families experience independence in the care of hemodialysis patients due to a lack of knowledge and skills. The therapy or the hemodialysis therapy can cause clients to feel unable and helpless to their physical limitations to carry out daily activities. So, if this problem not handled properly, they will have an impact on the worsening of the condition of the patients and families. So from this background, we interest to study about this topic. And this study or the purpose of the study is to determine the relationship between palliative care based on family-centered nursing and the level of dependence of patients with chronic kidney disease on hemodialysis at Ibnu Sina Gresik General Hospital. This slide it is about describe about the research method. The first one is design research or research design. We use correlational analytic with a cross-sectional approach, and then the populations is patient and their family with chronic kidney disease on hemodialysis in Ibnu Sina General Hospital. And the sample technique, we use consecutive sampling, and we have 120 patients and their families undergoing hemodialysis. Okay, and then the next one is it is about the research method too. For the questionnaire, we use palliative care based on family-centered nursing questionnaire, and this questionnaire have 47 questions. Have 47 questions and contains 8 subscales, and we use analysis or we analysis the data with Spearman rank correlation test. And before we get some data or before we get the data from respondent, we get health research ethic and patient and family informed consent. This is the characteristic respondent from this study or from this research. For the sex, 51 respondents are male, and then 69 are female respondent. And then the education, this is about the education. The education, 31 people graduated from elementary school, and then 31 respondents graduated from junior high school, and then 41 respondents graduated from senior high school, and then 13 respondents graduated from college. And the third one is about the income. for 54 respondents had income less than 2.2 million rupees, and then 66 respondents had more than 2.2 million rupees. And the fourth diagram is about relationship, the relation with patients. The first one, 78 respondent. The relationship with patient is husband or wife, and 33 respondents are patient's child or patient's children, and then the other is parent and siblings. And then about the hemodialysis durations, 87 respondents undergoing or have done hemodialysis 3 to 4 years, and then 14 respondents undergoing hemodialysis or have done hemodialysis more than 4 to 5 years, and then 19 respondents have done hemodialysis more than 5 years. Okay, and the other result in this slide, we will present it about two results. The first one, it is about palliative care based on family nursing. And then the second chart it is about patient dependency level. For patient care based on family nursing, 37 people or 37 respondent has a good palliative care based on family nursing, and then 43 respondents has sufficient palliative care based on family nursing, and then 40 respondent has or had a poor palliative care based on family nursing. And then the second diagram, it is about patient dependency. The patient dependency from the study, two people or two respondents had independent level, and then 107 had mild dependency level, and 7 respondents had medium dependency level, and then 2 people or 2 respondents had a severe dependency level, and then 2 people had a total dependency level. It means that the dominant of patient dependency is in mild dependency. And then about palliative care based on family nursing, the extreme number is this one is insufficient palliative care based on family nursing. Okay, and then this is in this slide, I will describe about the principle of palliative care for patients. The principle of palliative care for patients include the first one is assessing physical, psychological, social, culture, and spiritual aspect. So it means that we must assessing holistic, in holistic.
I'm sorry.
Psychologic,
Ibu
yes.
Isni, 5
Yeah.
minutes again.
Okay. So thank you. Okay, I will continue it further. The first one is assessing physical, psychological, social, cultural, and spiritual aspect. The second one is determining patients' and families' understanding and expectations. The third one is determining patient care goals. And the fourth one is providing information and education on patient care. The fifth one, performing symptom management and psychology, and assisting patient with advanced care planning. And the last one is providing services to patient in terminal stage. And the next slide is about level of dependence of chronic kidney disease patient undergoing hemodialysis. In this slide, we know that families assist patient at various stage the disease. family as treatment partners. It means that family members are frequently involved in the treatment of chronic kidney disease patients. And the second one is family as care partners. It means that family members are involved in variety of important activities from patients. So it means that from this slide, we can conclude that the family must understand about that principle so they can give a good palliative care for their family during hemodialysis. And the caring for hemodialysis patient will face several challenges and problems. The first one is frequent hospitalization. The second one is administration of various drugs to patients. And then the third one is preventing complication in hemodialysis patients. So, the result of the study is a correlation coefficient. There's correlation coefficient of the study is minus 0.348 with a significant value is 0.007 with the value value less than 0.005. It means that H1 was accepted. It means that there is a relationship between family-centered nursing, best palliative care on the level of dependence of chronic kidney disease patient with hemodialysis in Ibnu Sina Gresik General
I'm
Hospital.
sorry, Ibu Isna, time is over.
Okay, I will close this presentation with this one, the last one, the recommendation. It means that patients with chronic kidney disease who begin to experience dependence involving their daily activities needs family-centered nursing best palliative care skills by the family. So we as a nurse must understand about the point of the daily activities of patient and what is the point or center point of family-centered nursing best palliative care for family. Okay, thank you.
Thank you, Ibu Isni. Thank you for the interesting presentation. And then the second participant of oral presentation, Miss Dia Eko Martini. Ibu Dia, are you ready? Yes. Ibu Dia Eko Martini, time is yours.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
It is an honor to be presenter in this international journal seminar, ISMN, International Scientific Meeting in Nursing 2021. I am Diah Eko Martini, as the first author from Nursing Education Study Program, Faculty of Health Sciences, University Muhammadiyah Lamongan. This paper title is Determinants of Iron Supplementation Adherence Among Pregnant Women at the Puskesmas Sukio Lamongan. And this is my research has been looking at. Sorry. Anemia during pregnancy is a complication that often occur in pregnant women. This condition can be controlled by providing iron supplementation. Therefore, the government has set a policy of minimum service standard for the coverage of 90 tablets of iron supplementation during pregnancy. However, the adherence of pregnant women in consuming iron supplements has not met the expected target. An estimated 41.8% of pregnant women worldwide are anemic due to iron deficiency. The average coverage of national iron supplementation is 85.1%, and the average coverage of iron supplementation is East Java province in 2018 is still below the average coverage of 90.82%. Based on data from the nutrition section of the Lamongan District Office in 2018, the average coverage of iron supplementation in Lamongan District is still low. Non-adherent of pregnant women consuming iron supplements can have a great chance of developing anemia. Iron deficiency anemia can cause adverse perinatal outcomes such as miscarriage, bleeding, stillbirth, fetal growth retardation, low birth weight, premature birth, and neonatal death. Therefore, according to World Health Organization, its a large iron during pregnancy is not enough if obtained from food. Therefore, it should be helped by iron supplementation. Based on the background that has been outlined, the objective of this research are to know what is the determinant of pregnant women adherent in consuming iron supplementation. This is to improve antenatal care services at the Puskesmas so that the incidence of pregnancy anemia can be reduced. The research design in this study used a cross-sectional study. The population being pregnant women who had a pregnancy checkup at the Sugio Health Center, Sugio District Lamongan, during April 2021. The sampling in the study used consecutive sampling with 36 respondents. Data retrieval using questionnaire that have been tested for validity and reliability, then analyzed with chi-square test. This is the result, distribution of pregnant women based on demographic data. The table 1 shows that the majority of pregnant women aged 23 until 30 years, or 61.2%. While based on education, most pregnant women have a high school education background with a 91.7%. While based on gestational age, the majority of pregnant women are still entering pregnancy in second trimester, is still 63.9%. Determining factor of adherence of pregnant women in consuming iron supplement. This is the result. Based on the result of the study, we found that the majority, 66.6% of pregnant women comply with consuming iron supplement. Then pregnant women with good knowledge have 4.85 times more likely to comply with iron supplements. While pregnant women who have a good family support are 0.292 times more obedient in taking iron supplement. Similarly, pregnant women who regularly visited to antenatal care had a 0.227 chance to complying with iron supplement consumption compared to irregular pregnant women in antenatal care visit. Based on the result above, it can be concluded that
Ibu Dia, I'm sorry.
Yeah.
The time in 2 minutes again.
Okay. It can be concluded that the factor of knowledge, family support, and regularity in antenatal care visit are the determining factor of adherence of pregnant women in taking iron supplement. As for the motivation, a factor is known not to be a factor that affect adherence in. The conclusion is can be drawn from this research. This factor of knowledge, family support, and regularity of the antenatal care are factors that recorded significantly in determining the adherence of pregnant women in taking iron supplement during pregnancy. That's all my presentation. Thank you very much for your great attention. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Ibu Dia, for the nice presentation. Since the time is already over, please, Professor Josephine, give some comment about the complementary therapy in nursing or review about it.
Sorry, Ibu, what do you want me to do?
Yes, Professor Josephine, give some comment about complementary therapy or review.
The one that was presented. Sorry, I didn't get it. The one that is presented, Ibu Eka.
Yes.
Okay. I think the researches that was presented earlier. What is important is that it should be based on a scientific rigor, or there must be a complete research process, particular in the materials or in the way that it has been implemented. Okay, so I have not read or done or evaluated the researches, so I don't have any I don't have any position to evaluate these researches, but though it was presented today, I congratulate the two presenters for this presentation. And as a researcher advocate myself, I would like to reiterate or to promote the conduct of more researches specifically in nursing. Thank you.
Thank you, Professor Josephine. Well, with the presentation, the activities in the second session have ended. From the deepest of my heart, I do apologize for my mistakes in presenting this event. Thank you very much for your kind attention, and wassalamualaikum warahmatullahi wabarakatuh. For the next session, I will time for Miss Dia Ayu as Master of Ceremony.
Thank you. Thank you very much to the presenter, Mrs. Josephine De Leon from Central Escolar University, Philippines, and Nurse Eka Suryaning Tias as MCAS as a moderator. Now, we are going to begin our third plenary session. I would like to invite Nurse Siti Rizkika as MCAS as a moderator in this session. Let me inform her curriculum vitae. But I will announce for all participants, we will share the link, the attendance link is 15 minutes before today's conference ends. for Miss Siti Rizka, I would like to inform her curriculum vitae. She was born in Bondowoso, October 7, 1991, graduate of Diploma in Nursing Universitas Bondowoso, 2013, Bachelor's in Nursing Universitas Jember, 2017, Master of Nursing Universitas Erlangga, 2019, and working experience as a nursing lecturer, family and community nursing department, Prodi D3 Keperawatan, Universitas Bondowoso, editor-in-chief The Nursing and Health Journal. For Nurse City, time is yours.
Okay, thank you, Mrs. Dia Ayu, for your time. Assalamualaikum warahmatullahi wabarakatuh. Okay, for the first, thanks. I will say thanks to Allah for His blessings, so that we can stay here in a good condition. And in this opportunity, my name is Siti Rizkika as a moderator in the third session, and this is the last session of the International Scientific Meeting in Nursing, Rule of Microbiota and Sustaining TB session on the first day. Now, let us begin this International Scientific Meeting in Nursing. I will read the curriculum vitae of our third speaker, who's so amazing. She is Professor Yam Hong Ruangrat, Advanced Practice Nursing, Medical Surgical. She is a lecturer at Nursing Faculty at Buriram Rajabat University, Thailand. And for the expertise, chronic disease, diabetes mellitus, metabolic syndrome, nurse practitioner, and obesity. And for her research and professional experience, oral presentation title, Prevalence of Metabolic Syndrome in Local Leaders of Chumphang District, Nakhon Ratchasima Province at the First Nursing Innovation, a key to promote the humanized health in AEC era, Vietnam, December 5 until 6, 2014. The second is 7th meeting of the Asian Forum of CKD Initiative, Thailand, August 2 and until 3, 2013, and participated in the second autumn educational program of the International Activity for Health course of Kobe University, Japan, November 5 until 21, 2010. And the last empowerment program to develop competency on knowledge and performance in community of village health volunteers. Okay, that's a brief profile of our third speaker in this afternoon. She is very extraordinary. Okay, I will invite Mrs. Professor Jiam Hong Ruangrat. Professor, are you still with me? With us, sorry. Okay. In this session, Professor Yam Hong Ruangrat will present a very interesting topic with the title Nursing Guidance for Managing Side Effect to Drug-Resistant TB Treatment. Professor Yam, you have 30 minutes to present this topic. And Professor Yam, time is yours. Thank you.
Okay. I use only 20 minutes.
Yes.
20 minutes.
30 minutes.
Yeah. Wait a minute. I share my screen. I share my screen. I share. Okay. Good afternoon, everyone. Can you hear me?
Yes.
Okay. Sorry that I disturb your lunch. I take about 20 minutes not disturb your lunch. Everyone is very hungry, right? Everyone is really hungry. Me too. Before I talking about tuberculosis, I introduce myself. My name is Iem Kong Reung Rat. I am an advanced practice nursing and lecturer at nursing faculty, Buriram Ratchapat University. Before we talk about tuberculosis, I take a time for show Buriram province. Before I talk about Buriram, I would like to say thank you faculty of Health Science, Universitas Muhammadiyah Jember for inviting me to join today's event. Buriram is a province in northeast of Thailand, bordering Cambodia. It is multicultural province with beautiful castle and beautiful temple. Buriram is a sports city with world standard racing track and standard football field. Okay. Are you interested to play football with me? Are you interested to play football with me or for car racing with me? Okay. We have a standard international airport. A visit to Buriram is very convenient. You can direct fly from Bangkok Suvarnabhumi Airport to Buriram International Airport. Take a time about 2-hour flight. It's very easy to visit me. Hopefully in the future when COVID-19 pandemic is over, I'm waiting for you. Everyone visit me at Buriram province. It's easy to me. I warmly welcome. Okay, let's start. Let's start for tuberculosis. Okay. We have a fact about tuberculosis. Fact from WHO, a total of 1 million people died from tuberculosis in 2019. TB is one of top 10 causes of death and leading cause from a single infection agent. It is said. I'm really sorry. I'm really sorry, very sorry. In 2019, an estimated 10 million people fell ill with tuberculosis worldwide. 5.6 million men, 3.2 million women, and 1.2 million children. Children, most of them is beautiful, but why they are sick? This is a sad news. Key fact, in 2019, 1 million children fell ill with TB globally. Child and adolescent TB is often overlooked by health providers and can be difficult to diagnose and treat. What's up? Key fact from WHO, an estimated 60 million lives were saved through TB diagnosis and treatment between 2000 and 2019, ending the TB epidemic by
2030 is among the health target of the United Nations Sustainable Development Goal. Yes, this is I really sad because a children day is very innocent. Their world is beautiful. Their world is must be fun. Why they must be sick? This sad for me. In Thailand, we have a clinical practice guideline for TB treatment in adult 2018. Guidance tuberculosis diagnosis, people who have the following symptoms, like coughing for 2 weeks or more. This is in Thailand. Any of following symptoms such as idiopathic cough, hemoptysis, weight loss, fever of unknown origin, or night sweat should be screened for TB. Check yourself, please. Check yourself, please. Have any symptom? Have any symptom? Check yourself, please. For chest X-ray. Chest radiograph should not be used alone in the diagnosis of tuberculosis. Sputum should be examined too. In the event that there are no abnormality in the imaging, but the chest radiograph show abnormality in tuberculosis, it is recommended that all chest radiograph be compared to aid in the diagnosis. Okay. Sputum examination. Spot sputum and collect sputum. Sputum was tested twice. The first time at the doctor visit, and the next time it was sputum when waking up. Tuberculosis treatment. Before starting treatment, HIV must be tested in all tuberculosis patients. Consider monitoring liver function test in patients at risk of developing hepatitis, such as older adult, regular drinker, people with a history of chronic hepatitis. Blood test for renal function in patients with renal disease or at risk of developing acute renal disease such as nephrotic syndrome, chronic renal failure, diabetes with impaired renal function. Eye exam in elderly patients or those with pre-existing eye disorder. Okay. New patient regimen with drug susceptible. In 2017 World Health Organization tuberculosis treatment guideline. Yeah, in Thailand use this too. Okay. I'm really sorry. Some patients had to stop taking the drug out of necessity, such as severe drug allergies, unable to come for an appointment. It is recommended to check sputum before considering new treatment. Yes, because treatment after interruption, some people had to stop taking the drug out of necessity, such as severe drug allergy, unable to come for an appointment. Before start treatment, you check sputum before considering new treatment. Yeah. Multi-drug resistant tuberculosis. I think another speaker they talk about in detail of drug resistance in tuberculosis. So that this is a time for this is quick for me. Cause of drug resistant tuberculosis. I think if everyone is know, treatment provider lack of knowledge and skill in treating TB, such as improper dosage regimen, low dose therapy. All patients were not taking their medication regularly or not taking their medication due to side effect or social problem. deteriorating tuberculosis medicine or insufficient storage and transport system. This is the cause of drug-resistant tuberculosis. Okay, diagnosis of drug-resistant tuberculosis, testing for acid-fast bacilli, mycobacterial culture, and identification, drug susceptibility testing, and molecular biology. Principle of treatment and selecting of drug regimen drug-resistant tuberculosis drug treatment. In Thailand, we have two phases. Intensive phase, give kanamycin, moxifloxacin, clofazin, ethambutol, high dose, isoniazid, pyrazinamide, and prothionamide, give daily for 4 months. The intensive phase dosage can be extended from 4 months to 6 months in the case of sputum examination. In the 4th month, still found infection, and can extend the treatment period. The maximum concentration is 6 months if the sputum is still found infected after 4 months of treatment. Continue at phase. I'm really sorry. I'm really sorry. Sorry. Okay, this is that I talk about a treatment of a treatment. Oh, I'm really sorry. I talk about treatment of drug-resistant tuberculosis. We have drug treatment and surgical treatment. Drug treatment is intensive phase and continuous phase. For surgical treatment, indication for surgery are the location of the lesion is localized. Lung function that can be operated. That is when some lung tissue has been lost. Patient can also work as usual. Surgery is usually performed when sputum negative and have been on medication for at least 3 to 4 months. Okay. For nursing. In Thailand, for nursing care for patients with multiple drug-resistant tuberculosis. This is a loan of nursing in Thailand. Follow-up and clinical symptoms every month. Home visits every month. I'm very sorry. I focus role nursing care. I talk about role of nurse for home visit, for home health care. Because why I focus this? Because when the patient return to the village, we will have a team of staff from the sub-district health promoting hospital and village health volunteer to visit the patient at their home every month. We have village health volunteer who volunteer to help the health worker. These people work willingly without any pay with volunteer spirit. I'm proud to present in Thailand. We have a volunteer health village that help us for hospital, for home visit in patient. Hospital care alone cannot see all aspects of the patient alignment, but home visit can help take care of your health in holistic way, holistic care. Home visit to assess and plan ongoing care for chronically ill patients and their relatives to enable patients and family to better adapt to their chronic condition in accordance with the context of family and community environment. This is a picture. This is a picture for home visit in Thailand when we will visit the patient home with health worker to see if the patient is on medicine or not. All pictures that have been posted for permits from the patient already. Volunteer health, village health volunteer is very active in visiting patient at home because they know the patient and have a good understanding of the patient well-being. Okay, this is a picture that's home visit. Nurse is very important role in caring for drug-resistant tuberculosis patient because nurse explain information about the disease behavior and wearing protective equipment to control the spread of infection. Demonstrate how to wear protective equipment to relatives of patient. Counseling for patients and families to understand the need for treat and sorry, I'm very sorry. Okay. Counseling. A nurse is very important because nurse can explain information about the disease. Nurse is a counselor for patient and a mental care encourage or observe of the patient condition. This is a picture that I show you about home visiting. I'm proud to present about Thailand. We have a village health volunteer that help us to visit a patient with TB. Okay, this good effective for us for protect for care a patient. These are some problem in a patient that is far and far, but some difficult for us to visit them far, and this is difficult for traveling for visit them. I think for me I share like this. Have any question? I think it's a time for me because I think everyone is really hungry and too.
Okay, Professor Yam, thank you so much for your very good and very interesting topic today about nursing guidance for managing side effects to drug-resistant TB treatment. Okay, ladies and gentlemen, now we are in Q&A session. Please raise your hand and unmute your audio if you will ask to Professor Yam. Okay, participants, if you will ask to Professor Yam, please raise your hand and unmute your audio.
Okay, I will ask to Professor Yam.
Okay, Mr. Hendra,
Yes.
Mr. Hendra Kurniawan from Universitas Muhammadiyah Jember, sorry. Time is yours.
Okay, thank you for Narsiti Rizkika for your time for me to ask to the speaker. สวัสดีครับอาจารย์ยีอาม
สวัสดีค่ะ
สบายดี
สวัสดีค่ะ
สบายดีไหมครับ
โอ้สบายดีค่ะ โอ้ยขอบคุณค่ะ very very nice to see you to see all
Yeah,
of you.
nice to see you too.
Yeah.
Actually, I've been in the Northeast Thailand several years ago, about 4 years
Oh,
in Khon Kaen, อาจารย์
wow. Yeah, Buriram Park Khon Kaen about 1 hour drive. 1 hour
Yes,
drive. Yeah.
I've been to Buriram as well.
Yeah. Sport city. If you are free and when COVID-19 pandemic is over, warmly welcome.
Okay, Achan, I have one question for you, especially for maybe this is the this kind of sharing between Thai Ministry of Health and Indonesia, how Thai government manage the prevalence of tuberculosis infections. Since we know that the prevalence of tuberculosis infection in Thailand is very low compared to my country in Indonesia. So I just want to know about the tips for from the Thai government, especially from the Ministry of Health, how to move the volunteer to engage, to make the engagement with the community. Maybe that will important for us to Indonesian population to make a good relationship and engagement with the populations.
Okay, thank you, Mr. Hendra.
ขอบคุณครับ
About policy, health policy in Thailand, we have a village health volunteer that they can help us for a screening test in a village. We have a symptom of the first time we suggest volunteer suggest health volunteer about symptom of tuberculosis, and so that health volunteer they living in a village, so that they seeking people that have symptom like weight loss or sweet or a fever at afternoon or sweet, or they seeking and they ask because one volunteer, one village health volunteer responsive about 10 family, so that she know volunteer here almost is a woman, so that she know about people in their group. She's seeking and she asks, what happened about you today? Have a cousin, have a fever? How about your children? How about your father? How about your mother? They know everyone in this group that she responsive, so that they seeking. And if they saw someone have a symptom, they suggest go to a hospital for check your symptom. This is make us for screening for tuberculosis. And when we know who is a TB, we have the policy for early treatment. They walk into a hospital and to see a doctor. And see a doctor, and so that when a patient going back to this village, to her village, to them village, we have connect with volunteer health and health worker in sub-district. This is a connect to know, for example, when a patient came in hospital to see a doctor, after that they going back in a village A, so that we have a connect from hospital to a village A to connect about information about patient, about everything, so that we to visit them and explain about everything about sheep complaint about allergy, about drug allergy, about food, about exercise, everything. And if a patient have a problem, you can go to health center in subdistrict, and worker in subdistrict can call for a doctor. Yeah, this is in Thailand like this, in everywhere in Thailand do like this, so that we can control tuberculosis. Tuberculosis person is low and low. Yeah. It's clear
Okay.
for you, Mr. Hendra.
Okay,
Yes,
thank you,
Thank you.
Mrs. Siwam. Okay, Mr. Hendra, are you satisfied with the answer? Maybe or any feedback maybe?
No, I think enough. Thank you.
Okay, thank you.
Okay, thank you very much.
Mr. Hendra and Mrs. Siam. Maybe
Yeah.
all participant, want to ask to Mr. Yam. You can raise your hand and unmute your audio, or maybe you can typing on chatting in Zoom or in YouTube.
I think, sorry, sir. I think is you some question you can ask me in Facebook or in Line, because I think I think now everyone is hungry. I think. Okay.
Okay, Mrs. Yam.
Okay.
There is a question from Olivia Risni Singkita to Mrs. Yam Hong Rongrat. Can pulmonary TB be cured with complementary therapy? And are there any side effects for the patient?
Sorry, again, please.
Okay. Can pulmonary TB be cured with complementary therapy? And are there any side effects for the patient?
Okay.
About complementary therapy.
Complementary, yeah,
Yes.
yeah.
Okay.
Okay. We have a patient that someone denied for treatment from a doctor. They're seeking for complementary like voodoo treatment, like steroid treatment for complementary like that. We have a form for sign for deny a treatment. The patient must sign your name for deny this treatment. This sign is a show for a doctor that a patient they deny to treatment. They need to complementary treatment. Yes, this is clear for us. But for this is clear for answer.
Okay, thank you, Mrs. Yam.
Okay.
And for the last question, maybe Mrs. Eva, can you unmute your audio?
Okay, thank you, Miss Rizkika. ขอบคุณค่ะอาจารย์
ขอบคุณค่ะ Hopefully in the future we waiting for you at Buriram. We will invite everyone visit me at Buriram city.
in our seminar.
Yeah, thank you very much.
Maybe I question about maybe you can explain how to education in community about the lung TB in Thailand.
Sorry. Oh my. What's up about my computer? Okay, again, please, sorry.
Okay, maybe you can explain how to education in a community about lung TB in Thailand.
Mr. Hendra, help me, please.
You can explain to education in a community or in a village about model of education about
model of education. We education for attention like drugology, equipment in their house. They must isolate equipment. They must use a drug regularly, and they consider about drugology. And we educate them about environment in their families, and they separate from relative from family member, and so that when they have a problem like have drugology, the problem about severe drugology, you can consult me all the time. We have a card for them, the phone number 1669. They call all the time. Okay. Hello, this is a problem for me. This is difficult for us
Okay.
for in another way.
Okay, thank you for your answer, Professor Yam. And Mrs. Eva, how the answer? Maybe you satisfied or any feedback?
Okay, I think enough, Miss Ristika. ขอบคุณค่ะอาจารย์
ขอบคุณค่ะ ขอบคุณค่ะ ขอบคุณค่ะ
Okay, thank you, Mrs. Eva and Mrs. Yam. Okay, ladies and gentlemen, now this is the last session in question and answer, and then for Professor Yam, please don't leave this meeting until the oral presentation done. So stay with us until this oral presentation done. And ladies and gentlemen, for the next event was the oral presentation session. And our first oral presentation participant in the third session is Mrs. Lisa Maufiro from Faculty of Health Science, Universitas Muhammadiyah Lamongan. Mrs. Lisa, are you stay with us?
Yes, I'm sorry, Lilis, yeah. My name is Lilis.
Okay, I'm so sorry, Mrs. Lilis Maufiro.
Okay.
Mrs. Lilis Maufiro will present about the title, the development of preschool children during the COVID-19 pandemic. Mrs. Lisa Maufiro, Mrs. Lilis Maufiro, you have 7 minutes to presentation. Time is yours.
Okay, thank you. Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh. My name is Lilis Maufiro. I am from Universitas Muhammadiyah Lamongan. Good afternoon. We would like to thank the committee for giving me time to present the result of our research entitled The Development of Preschool Children During the COVID-19 Pandemic. The result of the research with 4 other research teams The condition of the COVID-19 pandemic is an international pandemic that is experienced in all countries, including Indonesia. As a result of the COVID-19 pandemic, preschool children, learning is carried out from home which will affect the child's social life. Several conditions such as isolation, school closed, reduced social life and physical activity, and change in routine and risk factor from the perspective of social development and preschool. This can be seen from the child relationship with the people around him, friendship, neighborly relation. That has an impact of the development stimulation that children get reduced with before the pandemic. Children get stimulation at school, the home environment, and at home, but during the pandemic condition, the developmental stimulation children get is only at home. Development of preschool children. Children are the dream of every family because they are the next generation. Preschool is a period of increasing development, so that is expected to develop optimally according to age. The development of preschool children increased by 80%, put the development of skill, fine motor, gross motor, language, social, emotional, cognitive, self-regulation, or independence. All of these development are the basic pillar for child development and development during adulthood. The factor that affect the development of children, especially preschool age children during the COVID-19 pandemic, cannot explain it. Therefore, effort to identify all aspects of child development during the COVID-19 pandemic need to be known in order to have stricten for preventing disorder in child development and accord toward optimal development according to age. The purpose of this study was to analyze the factor that influence the development for preschool age children during the COVID-19 pandemic, namely the factor of children's dietary habit, child nutrition status, child gender, parental education, parent age, and parent occupation. Method. The study is a quantitative study that uses a correlation analytic design with a cross-sectional design that to determine the relationship between children, dietary habit, and the development of preschool children during the COVID-19 pandemic. To determine the relationship between children nutritional status and the development of preschool children during the COVID-19 pandemic. To find out the relationship between the sex of the child and the development of preschool children during the COVID-19 pandemic. To determine the relationship between parental education and the development of preschool children during the COVID-19 pandemic. To determine the relationship between parental age and the development of preschool children during the COVID-19 pandemic, and to find out the relationship between parent work and the development of preschool children during the COVID-19 pandemic. The sampling used was simple random sampling with a population of 53 and sample the 47 preschool children aged 3 to 6 years at Tunas Melati, Celuring, Kalitengah, Lamongan. Results. Number one, more than half of preschool children have a moderate dietary habit, and from that number, most of their development is confirmed. More than half of preschool children have normal nutritional status, and from that number, more than half of their development confirmed. More than the majority of preschool children are girls, and from the figure, most of the development is confirmed. Almost all parents of preschool children are age 22 35 years, and from that number, more than part of their development is confirmed. Almost all of the parent and preschool children have junior high school education, and from this figure, almost half of the development is confirmed, and then more than most of the parent of preschool children work, and from that number, almost the majority of their development is confirmed. Discussion, the result of the study indicate that there is a significant relationship between dietary habit factor and nutritional status with the development of preschool children during the COVID-19 pandemic. The mean that the better the dietary habit and nutritional status of the child, the better the child development. The development of a child is influenced by many factors, including nutritional status. Nutritional status influenced by eating habit. Healthy eating habit in child are important in preventing growth retardation and acute nutritional problem in children. According to research, that their habit has a relationship with child development, where parents who have a good level of knowledge about eating pattern will be able to monitor and train children for optimal development, so that if there is a growth disorder in child, it can be detected early. This is probably because in this pandemic condition in minimalist the spread of COVID-19, people are expected to stay at home. However, it was found that there was an indirect relationship between this factor, because children still need the participant of parents in with the age, education, and occupation of parents will affect their knowledge, so that they can affect the role of parent in providing stimulation, implementing children eating pattern, and fulfilling nutritional will has impact on the nutritional status of children. With stimulation, a good diet of nutritional status will affect the development of children. This is in accordance with the result of the study Jayanti. That the role of parent can affect children development, namely from abilities and skill in nurturing and educating them. The higher the level of knowledge, the more able to monitor and train children to achieve optimal development. There is not relationship between the sex of the child and development during the COVID-19 pandemic, because during the pandemic, it has been more than a year that our children study at home and are active at home, so they do not get development stimulation from outside the home, with usually not in a pandemic condition. Other than children can be stimulated at home from parent and family member, as well as children can study at school, so that they get stimulation both from teacher and from peer and the school environment. But in this pandemic condition, children only get stimulation at home from parent and family member. Conclusion. The conclusion of the research is a relationship between dietary habit and nutritional status of children with the development of preschool children during the COVID-19 pandemic. And there is no relationship between the child gender, parent age, parent education, and parent occupation with the development of preschool children during the COVID-19 pandemic. Helpful usually and helpful we can participate in supporting children development. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. Thank you.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Mrs. Lilis Maufiro from Faculty of Health Science, Universitas Muhammadiyah Lamongan. Okay, we will continue to the next oral presentation. For the second participant is Nurse Wantiyah Magister Keperawatan from the Faculty of Nursing Universitas Jember. She will present about the title COVID-19, Public Knowledge and Preventive Behaviors. Nurse Wantiyah?
Yes.
Have you joined with us?
Yes, Miss Rizkika, I am here.
Okay, thank you. Thank you, Mrs. Wantiyah.
Okay, nice to meet you.
Okay, Mrs. Wantiyah, you have 7 minutes to present about your manuscript. Thank you. Time is yours, Mrs. Wantiyah.
Okay, thank you, Miss Rizkika. Let me share our presentation. Okay. No, this. No. Okay, sorry. This one. Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, all of the participants and also Prof. Yam. Okay, in this time we will present our research about COVID-19, public knowledge and preventive behaviors. Okay, as we know that COVID-19 or coronavirus disease 2019 as an infectious disease caused by severe acute respiratory syndrome coronavirus is being the world's serious problem, with the total case that has been elevating dramatically in everywhere. We can see that the number of the patient with COVID-19 is elevating or is increased. The people knowledge about COVID-19 is prominent aspect in deal with the behavior to prevent the transmission of COVID-19. Therefore, the aim of this research is to identify the relationship between the level of knowledge and COVID-19 prevention behavior within population. This research is cross-sectional with the correlational with cross-sectional, and then we did this research at the Rajopolo, Jatirojo Lumajang, with the population is about 1,031, with the sampling is 2,289. We conduct this research to gain the sample by consecutive sampling, and we use the questionnaires to gain the information or the data. It's about the characteristic of respondent or the demographic of respondent, and the second is about the COVID-19 knowledge, and the third is the preventive behaviors of the population. Before we did this research, we got the ethical clearance from ethical board, and also we did the ethical principle during this research. And then, okay, we using the questionnaire that was requested and then collected online, use Google Forms from among 289 respondents on March to April 2021. The questionnaires examined the demographics of respondents, COVID-19 knowledge and preventive behaviors that we adopt from Hussein T to 2020. We adopted and we translated to Bahasa Indonesia, and then we do the validity and reliability use ICVI. For the data collection, before we collect the data, we complete the administration from the faculty and also from the ethical board, etc. And then we find the sample, and after we do the administration, we send the questionnaires for to the WhatsApp group. We send the link for to the sample to fill the forms, and then the data that the respondent have been filled, it will enter to the link, and then we editing the data. We collecting, and then and the last we analyze the data by Spearman rank. Okay, for the result we can see in here on the type. For the gender, it is the majority of the respondent is female. Yeah, it's about 60%, and for the age, most of the population, it's the cluster is at adolescents. Yeah, and then the education, most of people or most of respondents are in the junior and senior high school or in the middle level of education. And then for the knowledge level, we can see from the table that the majority or the 79.6% of the respondents were at the good level of knowledge. Yeah, it means that actually in our population, people have known about the COVID-19 itself, yeah, including the etiology, the signs and symptoms, and also the prevention. Yeah, even though the majority have a good level of knowledge, we can see in here there are still many people who don't have the good knowledge. So it's become our challenge to improve the knowledge of the people. And then for the second variable, it's about the preventive behaviors. Yeah, from the table we can see that it's also in line with the knowledge that the most of people, it's about 84.8%, they have implemented the good behaviors in preventing the transmission of COVID-19. Yeah. In our respondent, they said that they filled the form, they said that they have done the 3M because before it's 2020 or before our government stated the 3M to prevent the transmission of COVID-19, but now we have 6M. The 3M is about how to do hand washing, wearing masks, and also maintaining physical or social distancing. And for bivariate analysis, we can see from the table that we got the P at 0.001. It means that less alpha 0.05. It means that there is a correlation between the level of knowledge about COVID-19 and preventive behaviors. Yeah, we can see from this result that the people who have good knowledge, they will perform a good better behavior in preventing the transmission of COVID-19. It is stated by Gladys 2016 that the tendency of people to behave well can be supported by their knowledge about healthy behavior. WHO 2021 also stated that the best way to prevent and slow down transmission of COVID-19 is to be well informed about the COVID-19 virus, the disease it causes, and how it spreads. It's very important for our people. So the conclusion of our research is that there is a correlation between the level of knowledge about COVID-19 and preventive behaviors in population. Hence, the higher the knowledge, the better the behavior to prevent the transmission of COVID-19. Therefore, public awareness to access the right information about COVID-19 is essential to enhance people in performing preventive behaviors during pandemic era. Yeah, I think that's all of my presentation. We hope that this pandemic era will be end soon. Thank you. The time is over to you, Ms. Rizkika.
Thank you, Mrs. Wantia, for your amazing presentation. Okay, ladies and gentlemen, we will continue to Q&A session. Okay, please raise your hand and unmute your audio. Okay, Mr. Ando Mangkuluhur, please turn on your audio. Mr. Ando.
Yes.
Okay.
Okay. Thank you, moderator, and everyone. Give me a chance to ask Mrs. Wantia. Okay. I follow Mrs. Wantia presentation about the COVID, about people knowledge, what is danger or more infection about the COVID-19 can affect their life. Okay. As we know, in Indonesia, COVID is not over, and every case we can look is improve, and calculating is improve more than more, and people get more worries about this, and also and my question to Ms. Wantia, what do people need to concern about this situation in a pandemic? That's my question. And people have a dream, have a hope this pandemic will be over, and that's not never want to be patient. That's my question. Thank you.
Okay, thank you. Mr. Ando Mangkuluhur from Universitas Muhammadiyah Jember. And maybe Mrs. Wantia can answer this question.
Okay, thank you, Ms. Rizkika. Okay, thank you, Mr. Ardo, for your nice question. I think it's become our challenge together in facing the day situation. As we know that, maybe I will inform you that our research is done in 2020 on March 20 and 21, and as we know at that time is the new era. Yeah, we can remember that in the middle of 2021, the number of COVID-19 decreased, and then maybe on June, on July, yeah, unfortunately the number increased again, and we face with the new variant Delta that is spread maybe faster and faster than before. Therefore, I think that it's still important for us to again and again, yeah, as you said before, that all of us, of course, want to end this pandemic. So it's need not only from the government, yeah, we as a public as I said on the suggestion, it's need a public awareness to gain the right information. Yeah, I think the most challenge is the people feel bored, yeah, with this situation. They don't aware with the situation currently, because they said that maybe as we know that in our community there are many hoax, or there are many wrong information about COVID-19, that it become our public confused which is the right or which is the wrong, because sometimes the hoax or the wrong information come from publics, yeah, come from public figure. So I think it's still back to ourselves, yeah. So we, especially as a nurse, so we have to be the role model of our society. It's started from our smallest, yeah, from our family, from then become outer to our society. We have to be the role of the behavior, such as for wearing the masks. Yeah, at least now we have to the double masks. Yeah, we also reduce the we have maintaining to physical distancing, etc. Because yeah, I think Mr. Ando as the young generation, yeah, is the role model that people will follow. Hence, yeah, if we are the high education, also of course the public will follow us. Yeah, so I think it's the most important is we as health provider, as a young generation, and especially as nurse also, we have to be the role model for the public. So I think, yeah, even though maybe our behavior not give impact to our society, but I think, yeah, by the small to small, I think we will give the impact to the community. I think that's, yeah. So I think it's important for us to increase our iman, our immune, and our aman. Yeah, I think we all of us know about that. Okay, thank you, Ms. Rizkika.
Okay, thank you, Mrs. Wantia, for your amazing answer. And in this afternoon, this is a very amazing discussion, maybe, yes. Okay, for the next session, Professor Yam, have you joined with us? Professor Yam. Okay, before, thank you so much for our two participants in this oral presentation. Maybe for the last session is a closing statement from Professor Yam Hong Ruangrat. Time is yours, Professor.
Okay, nothing for me, but I think this is a good opportunity that we share idea for take care about tuberculosis patient. This is Ila. There's good opportunity that to share about research, about a knowledge, a new knowledge, traditional or working or special local. That's to share that we know that tuberculosis is a similar patient, but when we working, we have a special area for us. A different in working, but we have a goal. We have a same goal that is for help our patient to save away from drug allergy, to save life, to save them in good health. I think this is an opportunity for me, and really nice to see you, and hopefully waiting you visit me at Buriram, Thailand. Waiting for everyone. Thank you. สวัสดีค่ะ ขอบคุณค่ะ
Thank you so much, Professor Yam Hong Ruangrat. And then thank you for all speakers, Professor Yam Hong Ruangrat, Mrs. Lilis Maufiro, and Mrs. Wantia, for this amazing sharing your knowledge and experience to us in the third session. Maybe I am Siti Rizkika as a moderator in the third session. I want to apologize for all my mistakes. Thank you for your attention, and I will return this event to Mrs. Diah Ayu to will be continue this event. Thank you so much, everyone, and thank you so much for this opportunity to me as a moderator. Mrs. Diah Ayu, time is yours.
Thank you. Thank you very much for Ms. Yam Ruangrat from Buriram Rajabat University, Thailand, and Nurse Siti Rizkika Eskep MHOT as a moderator. The third plenary session has delivered with excellent discussion, and now we are in the end of our first day International Scientific Meeting in Nursing 2021. To all participants, Certificate will send to your email gradually in 1 week, as well as the certificate will give to those who join today's of the meeting by fill your data at the attendance list. Don't forget, we still have 2 plenary sessions, which will start tomorrow morning at 7 a.m. Indonesian time, with 2 speakers from Indonesia and Taiwan. Lastly, thanks for all participants for joining this first day. See you tomorrow, and wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Pandemi COVID-19 belum berakhir, bahkan angka lonjakan kasus semakin meningkat. Hal ini bersamaan dengan Badan Kesehatan Dunia atau WHO yang menyebut munculnya 4 varian baru hasil mutasi virus corona, yakni Alpha, Beta, Gamma, dan Delta. Keempat varian virus tersebut dianggap lebih cepat penularannya dan kini telah masuk di Indonesia. Oleh sebab itu, Mari mawas diri dengan tetap menjalankan protokol kesehatan yang sama, menggunakan masker, menjaga jarak, dan cuci tangan dengan sabun. Berikut 5 hal penting cegah penularan COVID-19. Pertama, membiasakan diri mencuci tangan dengan menggunakan sabun dan air mengalir selama 40 detik dan tidak terburu-buru. Jika tidak ada air di sekitar kita, maka gunakanlah hand sanitizer. Kedua, gunakan masker saat keluar rumah dan berinteraksi dengan orang lain. Selalu jaga jarak dan hindari kerumunan. Ketiga, segera bersihkan diri dan ganti dengan pakaian yang bersih saat tiba di rumah. Hal ini mencegah penularan virus pada anggota keluarga. Keempat, menerapkan etika batuk dan bersin dengan menutup mulut dan hidung dengan lengan atas bagian dalam. Gunakan tisu dan buang pada tempat sampah tertutup dan segera cuci tangan dengan sabun. Kelima, hindari stres dan tetap optimis saat melakukan aktivitas sehari-hari dengan tetap menerapkan kedisiplinan protokol kesehatan pada diri sendiri. Biasakan saring informasi media melalui sumber terpercaya. Apabila Anda mengalami tanda-tanda penularan COVID-19, jangan panik dan jangan takut untuk segera periksakan diri Anda. Mari disiplin diri hadapi COVID-19. Mawas diri, menjaga sesama.